Good morning. Good morning. Good morning. Good morning. My name is Bongile Chabalala, and I'm the National Chairperson of Treatment Action Campaign. representing people living with HIV in many national structures and international structures. Like to welcome you all here in this key population accountability meeting. Here in this program, we are going to look on the state of healthcare for key population specifically. Before we start our program, I would like to acknowledge people who are here in the room and online, people from National Department of Health. We welcome you and thank you for availing yourselves. And we have Austin Jones from PEPFAR, Helen Savia from CDC, Ashley Frost from USID. We have Jaya from PEPFAR, Joseph Lawrence from USID, Marisa from USID, and all the key populations that are here in the tent. I want to say in the room, but yes, it's our room for now. And also, I would like to say we are joined by other colleagues and comrades in all 7 provinces except Northwest and Northern Cape. So we have other sub-events which will be joining us on this community accountability meeting. So as we are continuing with our programs, we'll be looking at the Ritshidze data that has been collected, testimonies and discussions, challenges, and also solution, which should be led by the team here in the front. And we are also going to hear response from the Deputy Minister, Lomo. He'll be joining us online. And we'll have response from Jaya, who's here in person, and maybe somebody from CDC and USID. And also we'll be also getting responses from John Ochero from Global Fund, who will be joining us online. And yeah, if possibly there is a person from National Department of Health in the room, and also will get community response and or concerns. So that's how, and I'll be doing the closing. Also, just to note that translation will be provided because other people are comfortable to speak in their local languages, so there'll be a translation in between. So without wasting any time, I will hand over to my colleague James.
Good morning, everyone, and thank you for joining us. My name is James, and I'm a researcher on the Ritshidze project. So I'll just be taking you through the overview of developing the report. The second edition of the Ritshidze State of Health Care for Key Populations report has been developed using a combination of qualitative and quantitative data collected through a large-scale data collection effort with a team of 146 key population data collectors. This year, over 9,000 surveys were taken, combining interviews with 2,349 gay, bisexual, and other men who have sex with men, 3,353 people who use drugs, 2,290 sex workers, and 1,145 trans people. Some individuals with multiple identities, for example, a trans person who is also a sex worker or a sex worker who also uses drugs, engaged in more than one survey to reflect multiple identities. The quantitative data collection took place between July and September 2022 across 21 districts in 7 provinces across the country. Additional qualitative data collection took place from May to December 2022. All the demographics and the districts are outlined in the actual report that can be found along with our data collection tools and data dashboard are all available through our website. Members of the key populations were identified through snowballing sampling, where initial participants were asked to refer those who they know, who in turn referred those who they know to participate in the survey. Compared to the facility-based sample, this methodology allowed us to find more hidden key populations who may not use the facility, in addition to those more regularly accessing services. So let's start with an overview of where people we interviewed are accessing services. Overall, 12% of key populations we interviewed were not accessing services anywhere. The highest proportion of gay, bisexual, and other men who have sex with men interviewed were not getting services anywhere was in Gauteng and Mpumalanga, where 13% of respondents replied that they don't access services anywhere. The highest proportion of people who use drugs interviewed not getting services anywhere was in KwaZulu-Natal, where 24% of respondents replied that they don't get services anywhere. While in terms of sex workers, the highest percentage was in the Free State, where 15% of respondents replied that they don't get services anywhere. And the highest proportion of trans people interviewed not getting services was in the Eastern Cape, where 14% of respondents replied they don't get services anywhere. The majority of key populations interviewed by Ritshidze use a public health facility to access their health services rather than a drop-in center, mobile clinic, or private doctor. In fact, many key populations we spoke to are not even aware of drop-in centers, including 79%, which equals to 1,484 of the gay, bisexual, and other men who have sex with men, 75% of people who use drugs, that is 2,268, 74% of sex workers, which is 1,539, and 71% of trans people, which is 669. Many of those who were aware of drop-in centers said that these centers are too far away from them and they cannot afford the cost of transport to access them. Yet at public health facilities, key populations are often treated very poorly by clinic staff who at times shout or verbally abuse people, questioning people's sexuality or gender, and how or why they engage in sex work or take drugs. As expected, based on the evidence collected again this year, key populations using facilities on the whole had far lower satisfaction levels compared to those using drop-in centers and mobile clinics, having actually worsened significantly from data collected in the first edition of this report across each population group. Given that public health facilities are the entry point for many key populations into the health system, it is critical to ensure that a friendly, respectful, safe, and confidential environment for all, with services that cater to key population-specific needs. Key populations who are treated badly, humiliated, fear their safety, or even refused entry will inevitably not come back to the facility, be it to collect ARVs, HIV prevention, or uptake other health services. We cannot abandon key populations who are not able to get to drop-in centers. In addition, for key populations to actually uptake key population-specific services offered at the facilities, spaces are needed that they feel safe at and comfortable enough to disclose that they are part of a key population without fear of poor attitude, discrimination, or abuse. These issues must be addressed to ensure that the key populations are not left behind in the prevention of HIV and reaching the UN/AIDS 95-95-95 targets. More than 92% of people interviewed this year had not engaged in the Ritshidze project in 2021. The robust sample of key populations in this 2022 survey continue to raise issues around the inadequate access to specialized services. This results built from those from 2021, again, showing that more facilities must be specialized to meet the needs of key populations in South Africa. I'll now let my colleague take us through the first set of issues.
Good morning, everyone. My name is Londiwe Kuzwayo. I'm the KP organizer based in KZN. So I'm going to be taking you through the following slide. First, we are going to look at the public health facilities. The first group of issues are on staff attitudes at the facilities. Ritshidze data revealed that staff at the public health facilities were less friendly and professional to key populations compared to the drop-in center and the mobile clinics. This is consistent across all the key populations group, with just 37% of respondents reporting that the facility staff are always friendly and professional toward the men who are sleeping with other men, just 24% toward people who use drugs, just 46% towards sex workers, and just 41% towards trans people. While all populations groups faced unfriendly and discriminatory services overall, people who use drugs faced the most unfriendly services. Someone we met in Durban told us that the clinic staff discriminate against him because they say sometimes he comes there dirty. He said, "We need medical attention too. We are all the same. We are all human beings. Most guys die on the road while there is clinic next to them because they are known to not be helping them." We asked people who thought staff were unfriendly, which staff were unfriendly in particular. The following graph will be showing how clinical staff were, again, this year, the most commonly reported as being unfriendly and being unprofessional towards all key populations group we followed by security staff. No one should have to suffer abuse and humiliation to access healthcare in South Africa. Unfriendly staff was also the top reason given by those who told us that they had stopped going to the public health facility altogether, including 59% of men who are sleeping with other men and gay and bisexual people who didn't use the healthcare facilities, 50% of people who are using drugs, 58% of sex workers, and 50% of trans people. Similarly, for those who had stopped accessing healthcare entirely, unfriendly services was the most common reason they gave us, including 45% of GBMSM, 50% of people who are using drugs, 53% of sex workers, and 49% of trans people. One non-binary person we spoke to had said, "I no longer go to the facility, same as other gay people, because the bad treatment that we get there, which is very unfair, we should be treated equally like other people. The staff is very rude and very disrespectful towards us." Where the attitude of clinic staff have become unbearable, some people have stopped going to the facility altogether, including for HIV, TB, STI testing and treatment. For key population who are also living with HIV, just like all people who are living with HIV, it is critical to be supported to start and importantly, to stay on ARVs. Because people who are KPs are people in South Africa before they are KPs, just like everyone. So they have the same equal rights to healthcare as everyone. Where key population do miss an appointment or a few pills supporting people when they return to the clinic, it is essential to support long-term adherence. The guiding principle of the adherence guidelines describe how staff should be friendly though, and welcoming, and acknowledging the challenges of lifelong adherence. Yes, Ritshidze data show major gaps in friendly services and its public health facilities. That means key population living with HIV at times are worried about returning to the facility or even disengaging from care altogether, rather to face being discriminated against, being judged, or shouted at upon return. Shockingly significant number of key population reported having been refused access to services in the last year because of being a key population, including 5% of GBMSM, interviewed 19% of people who are using drugs, 12% of sex workers, and 9% of trans people. As many as 25% of sex workers in the Eastern Cape and 26% of people who are using drugs in Mpumalanga have been denied access to services. This is absolutely unacceptable and goes against the Section 27 of the Constitution. For key populations trying to access much needed healthcare, being chased away can make it more likely to deter future attempts. 55% of men who are sleeping with other men and gay bisexual people, 72% of people who are using drugs, 58% of sex workers, and 44% of trans people who have been denied access never go to get the services that they needed. While some of key population are aware of drop-in centers and can find taxi fares to travel to them, many are not so lucky and they have to use public health care. Being refused entry to the only source of health care for you can leave you with no other option but to disengage altogether or attempt to be given to a transfer letter to another clinic. From the very clinic that refuses you the services, often meaning an additional travel cost to a clinic further away from you. That's if you are even able to get the transfer letter. In October to November of 2022, Ritshidze data collected in facilities revealed that 506 people complained about being denied access to services without a transfer letter in the last 3 months. All reports of key populations being refused entry to the public health facility or their services are restricted should be urgently investigated with swift action taken to resolve this situation. We will now move to recorded stories.
Hello, hi. My name is Millicent Makhachiwa Sibota. Ki attend clinic ko Empilisweni. And kile kabali buthata before go Empilisweni. And then bothata baka ka complain ka bona. So ke nahana go bothata baka bonile go solvegile ma go tsile nakonyana. So I went back go clinicing because of ke ne decidile go tlogela treatment. And then ka boela go clinicing ba re-initiate for treatment, but still the treatment was the same. I wa change nix. They started misgendering me because of I identify as she as a transgender person. So ba staff ke nagana ga sena se tlhoka sensitization, se tlhoka education ka MSMs and key pops. So basumula ban misgender and abasumula ban misgender, I felt offended. Kaya go charge nurse, kaya complain about charge nursing. So in Nagare, I always have something to complain about every time I get a facility. And then they started being funny towards me. So I ended up getting a facility, kaya go another facility, which is Tsolofelo clinic. Thinking go Tsolofelo because of there's an MSM working as a health worker go thing. Dilo dia gonna much better and much easier. And then go Tsolofelo, I had to start go class. Bang re-initiate le bone go tswe madi go duweng.
Ebo ngisebenza clinic yase 19 store sami sibase u-HIV ne-TB. Kusebenzisa kwami i-clinic la ngeke ngitestela yinang i-HIV bese ngaze ngacala ukutesta ku-mobile clinic. Ukutesta ku-mobile clinic wami Ankoso uthinge e-clinic straight. Mangifika e-clinic ngafike ngatesta ngathola ukuthi ngiyi-positive. Uthola kwami ukuthi ngi-positive but ngize ne-partner yami uzokwazi ukuthi manje bonakala ukuthi nayo i-positive noma i-negative. I-problem yami engaba nayo ukuthi mina aqala ukuthandana namantombazane kahle. So ngigcina ngabona kahle umuntu othandana nabantu besilisa. Ngoba nami umuntu wesilisa. So kwenzeka ukuthi manje kufuneka i-partner ngaba nenkinga ukuthi manje nginalo kusaba ukuthi ngize nomuntu wesilisa because bangazi ukuthi mina ngithandana nomuntu wesifazane. So ngasaba lapho ke e-clinic ngagcina ngithola ukuthi manje lento seyangicindezela because uchubekela phambili azange ngikuthola ngoba ngisaba lokuthi ngiyoveza ukuthi lento nginayo and i-partner yami ayikho ngapha ukuthi ngiveze lapha e-clinic. Yona yak-affecta lo indlela yokuthi ba-treatana le ndlela ba-treatana ngayo because ingenza ukuthi umuntu agcina agula angayi ko-testa ngoba usaba ukuthi manje usaba ukuthi uzoveza lo muntu athandana naye ngoba i-gender yabi iyafana. Yinto eyenza ukuthi sigcine sisaba futhi nayo leyo. Ngithi unalo kusaba mhlawumbe uyasaba ukukhuluma umuntu anga-understand ukuthi kwenzakalani akuthethise nawe ugcine ubone ukuthi hayi lento yala ayikho. Ugcine ufuna nokutshintsha i-clinic ngale ndaba yalento le. No into engayenza mina lokuthi ngibuye ne-partner yami because mina bengisaba. Ngasaba ukubuya nayo lapha ngagcine ngathola ngi-treatment ngagcine lokugula sekugcina kungibamba. Kwakukhani ke sekuzoqala ukuphuza i-treatment after sengigula la kubona ngathi ngiyagula manje.
Now we will hear from community members who have joined us here today.
My problem came up a counselor how many girlfriends do I have? No. I said I'm a transgender. My pronoun is she, so I don't have a girlfriend. I'm dating men. So I got this Christian story. No, you can't be in a relationship with another man while you are a man. I said, I sat her down and as a trans person, I explained myself. And this is not my job to tell you. So for you as a health worker, and especially a counselor, HIV/AIDS counselor, so I started retort. So it took longer than expected, more consulting, and then the other sister came in. Was taking long. So the lady I'm explaining, no, she's explaining to me, why umita she, why umita she, and then I tried to explain. Another time ago, mamelana le ditori tseo tsa gago tseo. Obuti mo gonna ka re no ke nna Millicent ke kopa so ha sheba mo bukeng ya ka re use di buka di A4 books for registering and go kwala everything e re dira. So a re mo gonna no o thabang mo go kwetsi thabang mona ka re ya my preferred name is Millicent. A re bereke yalo gona ha re bereke yalo mo clinicing e ha o le thabang o thabang and o thabang o hi ha rena na kwa dilo tseo so o tlo re senyetsa na kwa bone di patient tse di re emetseng di kae. So she was so rude.
The way we treat one cat mo di clinicing kana le mathata a serious kana le mathata a kitse hore ba treata like rona e se frele batho ba bantsho hore yang ke la bona. So next we said clinic ya mo Potchefstroom ne ke le ka tla last year mo Potchefstroom ka tlo kopa medication wa ka ke inwela ARV bana ba se right for nna the way bana ba bua le nna ka teng bana ba shoutisana ba sa khone bua right ba mplela gore tlamne ke tsamaye ke mo ke dulang teng ke lo batla referral gore ke tle mo ke khone go thola medication wa ka as nsebetso go etsa ke travel hohle so mo Potchefstroom ne ke tlile fela ka o tlo kopa medication wa ka gore because next ke bona gore ke a fellwa and it's tlamehile ke itswe hape ke lo travel ke ye kae wa bo ke ne ke tlile ke tlo hlaba spade ne so ba nshautile ba mpela gore ba ka se ntlhabe ke lo batla referral ke tle mo bontsha gore ga lentse ke hlaba mo ntse ke dula teng okay fine ka ya mobile mo mobile ke kopile o hlabiwa spade because ba nentse ba hlaba batho because wa itse mobile ke go sebetsa everywhere okay fine a fitla mobile still ba ntse ba mplela ntho one gore tla le referral go bontsha gore re gone o bulela karete gore o gone o hlaba mo rona okay fine ka gawana ka decide gore e re ke ikela chemistry ke tlhabela chemistry every month ke ntsetsa 80 rand ka tlhaba ka mo ke a spenda ke reka dipidisi tse ke dinwang o ga ke sa di reki chomi ya ka ke yanang hafulela ngo tsa hae ga di share ga di bala like trinke ka o lekana gore ke gone o dula ntse re eno re le sharp mara ke na le bothata ba yone go re na ha ke tsebo re na ke eme kae gore na ke o dimo gore ke a fatsa kitse usually as usual ba tseba gore mosebetsi o go etsang ke mosebetsi o like a ke itse ke tla o hlalosa jwang o risk re thole medication ka nako re kgone o thola le di something tse tla re tshireletsa mosebetsi o go etsang o risk too much what if sometimes o kopana le motho condom ya blast o sa feditse already ha ona ntho tla bo etse o etsa something like wow ke rape o etsa rape o tla o bona o fitla o tla o tlolla o ba bolella gore ke etsa mosebetsi o so ke kopane le motho o go betse le nna ka first e batla ba bolela a ke go etsa mosebetsi o no lebeletse go etseng ke nthonyana tse re di tholang re fitla mo clinicing
bengihlala kaMashu but manje sengihlala la eThekwini ngosizo like ebengilifuna ngesimanga sokuthi bengibhema ama drugs nakhona ama drugs lawa ngiholela ekutheni ngicine ngizengidayisa ngomzimba bo so njengoba ade ngidayisa ngomzimba bengihlala la kaMashu ama clinic like akhona bengiwahamba nawo like izinto eziningi njengama medication izinto obungayithola bo then ngase ngagcina sengidlulela kulezi ezinye izibhedlela ngoba since bengisex worker kuthe like ngoDecember bo ngaba nesilonda la ngaphansi bo mangiba nesilonda kwaphoqa ukuthi ngihambe ngesibhedlela bo mangifika esibhedlela like igama lesibhedlela eDington yabo lonto mangifika eDington ngafika ngabamba line kwaze kwa like kwaphela usuku wacaca ukuthi usiza ngilithola mangibuya ngikusasa ngosimanga sokuthi inkinga yami ayi serious ngempela ukuthi angikhona ukuphumula angikhona ukulala ngoba nayo mangabe ngiyo sex worker like ngisuke ngithola imali yabo but then mase ngasaphansi obviously imali angiyithola kudingeka ukuthi ngiphoqa ukuthi usizo ngiyalithola then ngiqhubeke ngihambe ngiyokwenza umsebenzi wami ukuze ngibe right yabo so then ngaphinde ngabuyela esibhedlela so ngasimanga ukuthi mina bengibhema bo lonto esibhedlela ngabona nendlela abebengithatha ngayo ukuthi no laba bangithathisa komuntu ophilayo yabo babona nendlela engiyona nangendlela engcole ngayo ukuthi no ongenze ukuthi babone ukuthi angene nomuntu yabo ngoba nami isimo engangikusona since mabo mawubhema like kuba nesikhathi sokuthi okay njengoba ngiyi-sex worker kumele ukuthi ngiyogeza ngoba kumele ngiyophansi lokho akuzange ngungiphathe kahle nakancane ngoba ngabona ukuthi shusi mangabe uyi-addict uyi-drug addict shusi wena usiza utholi like ngendlela efanele njengabo bonke abantu nanokuthi mangabe uyi-sex worker ngoba angithi ngichaza ukuthi siphila yiphi impilo imali into like ehlezi uyidinga ngaso sonke isikhathi so ngalesikhathi sibona bengimisa obvious lapho impilo yami ayiqhubeki yabo lonto
Sanbonani.
Greetings.
Dumelang. Right. My name is Vuyani Tafeni. From Free State.
Free State.
In Bloemfontein. I'm using Gabriel Ritshidze. In Bloemfontein. So in like yam ila.
My problem is here.
Attitude.
Staff attitude.
Staff attitude ngendlela ukuthi I don't know it's because of I'm gay or not.
The staff has such a bad attitude.
Because each and every time when they see a clinic, they throw.
Give me time. Because each and every time I'm at the clinic,
they throw weights. They be call me drama queens.
Drama queen.
You
think you know better?
I don't know why. They even denied me treatment. They said the whole month. December dingena treatment
I spent the whole month of December without having my ARV
because
treatment
dingena a transfer letter.
because I didn't have a transfer letter from my previous
But
facility.
ngibuyele clinic bendiyisebenzisa ngizile transfer letter.
They said I should go back to the previous facility and bring a transfer letter.
Xa ndibaxelela I'm not a defaulter. I'm using a clinic bayala.
I explained that I hadn't defaulted, but I'm just here for some time. They didn't
So-
give me the treatment.
Ndicinga ngokuthi
So I think
we need to fix the attitude of the staff, especially at Gabriel Ritshidze. Because now I end up coming to Pretoria ngizofuna uncedo.
to find assistance in Pretoria, I eventually had to come to Pretoria to get assistance.
So Gabriel Ritshidze denied me treatment, denied me my rights. So we need to fix that. The attitude, especially ama admin clerk, they have bad attitude. They act like they are nurses and sisters and whatever. Those admin clerk, they have bad attitude. You can't call somebody a drama queen because of he's gay, because of he know his rights. Then you call him a drama queen. So I think we need to fix that. Thank you very much.
Thank you.
Sanibonani.
Greetings.
Anonymous ngizishikama. Okay, mina story sami it's also about the attitude and the way they treat us as sex workers. Me, I'm from Durban. The first clinic I attended was Eddington. Since I was sick, I didn't know what's the reason. So I went to Eddington, and when I got there, it came to a point where they asked me where I work, where I live. So I had to tell them. Instead of that, they made more than 11 people jump in front of me in the line while I came along. So I waited for a while, and then when it was my turn to get inside, the sister asked me what's my problem. I told her I don't know. That's why I came here. So I checked my things, and then I found out I'm pregnant. And then first of all, she judged me and said, "Wow, you're so young. You're a sex worker, and you're pregnant." She said,
She advised me to abort the baby.
and I was like, no, I'm not ready to do that, even though I don't know what I was going to do at that situation. So they passed me on to another room where I found an Indian woman and a black woman. So I just kept quiet in the room, and they were speaking English. She probably thought I didn't understand English because since I came in, I was speaking my language, Zulu. And she said, obviously, she's a prostitute. She obviously wants abortion. Just give her the paper to sign. So the black woman just came with the paper to me and said, it's a paper for me to start a file that I'm pregnant. She really thought I didn't hear the Indian woman saying that I'm going to sign a paper for abortion. When I tried to stand up for that, they didn't help me because I was my level. I couldn't get to the point where I could ask for a manager because they would just laugh at me, say I must wait there, wasting my time. So I just want them to kind of fix that problem at Addington. The attitude there, too much.
A very good morning to everyone. My name, public. My name is Salim. My surname is Adam. I'm from KZN. So the clinic I was using was Shaka Square Clinic. So a friend of mine and I had problems health-wise. So we took our time, like, you know what, today let's go to the clinic. We went there. We sat for an hour and a half with no help. So we asked why we didn't help. We're like, and an Indian nurse came and she was like, it's against my culture. I cannot help you. We'll wait for somebody else to help you. A male nurse came in and he was like, no, I don't help gay people. Can you please wait again? We waited until the day was finished. We left without finding help. The following day, my friend, let's use a different clinic from this one. We went to a different clinic, of which we were helped within an hour or so. We're done because in Grover Clinic they have a nurse called TP Keswa, I think. Yeah, she works for ANOVA. So she helped us. She gave us lubricants. She gave us health treatment. She checked us everything. So my issue is, why is the nurses have to analyze my sexuality in order to help me? Is it possible to help me without knowing my sexuality first? Because the main issue I came to your clinic is for health and help reasons. So my issue is it possible at least to change nurses? I know it's not possible, but yeah, I think it's possible. So the staff is actually not friendly. Some are don't, and some only love drama that we bring. So most gay have drama, so some will like, just have the drama for now. Then they're like, no, I'm going to lunch, wait for somebody else to come help you. So I think when it comes to ARVs, lubes, and condoms, it's very hard to access that when you're gay or a lesbian. Thank you.
Sanibona.
Greetings.
Anonymous. Shuthi mina story sami bengitujuliwe.
I got shot
Ngihamba ngiye esibhedlela eDingisini.
and went to Editon Hospital.
Security la ngiphatha kahle la ngikhomba konesi.
The security guard assisted me properly and showed me where to go.
Mangifika kunesi unesi angitshena ukuthi angilinde kancane. Ekubeni security lithe angiye kuyena ukuze ngikwazi ukuthi ngiswe ku-emergency room ngokuthi ngangopha kakhulu.
The nurse wanted me to wait, whereas the security had advised me that because of my excessive bleeding, I had to be assisted immediately.
Nami ngalinda shuthi mangibona ukuthi isikhathi ngendlela esihamba ngayo nokuphelelwa amandla mangiphinda kuyena unesi aphinde angakhulumi kahle namakhombisa ungangihloniphi.
I waited and eventually went back to the nurse to request that they assist me, but she disrespected me and responded to me rudely.
Shuthi into yagcina yenze ngigcine ngikwazi ukuthi angifake ibhandishi anginike amaphilisi einhlungu kuphela ekubeni bethe udokotela bazongisa x-ray.
So the doctor had said that I was supposed to be taken for an x-ray, but because I had kept on going back to the nurse asking for help, she eventually gave me a band-aid and painkillers so that I can leave the facility.
Mangimbuza ukuthi why ngalinde udokotela ukuthi bangise x-ray yena wathi angihambe athi kumina afuna le ngilinde udokotela basaye kuyilunch ngiyabakwazi ukuthi bahlale balinde iphara bazosebenza iphara instead of ukuthi bathathe lunch yabo.
When I asked her why am I not being made to wait for the doctors to assist me and take me to the x-ray, she said that the doctors are at lunch and they are busy with other patients. They cannot be brought back from their lunch to assist the drug addict.
Shuthi ngagcina ngisengiphenduka ngisho ihlaka ngoba agcina ngisho sengihamba sengwashiya kwamaphilisi.
I eventually felt like I was being made as a spectacle in the facility and I left without even taking the painkillers.
Ngiyabonga.
Good morning, everyone. My name is Tabang. I'm from Freedom Park in Dublin. My case is very severe. Actually, there are multiple ones. At first, there was a time whereby I got stabbed. And then I went to the clinic to get help. When I got there, the normal procedure wasn't followed because when I got there, I was sent to reception, then I got my card. After that, I was sent straight to the emergency room to get stitches. One of the nurses asked, isn't this wound very deep? Can he go get tested, checked by the doctors first? The other one was like, no, these people go get drunk and then come to the clinic. The clinic is very full, the doctor is very busy. I went to the emergency room, I got cleaned and stitched. That was it. After a couple of months, as even now, I get headaches and I get swollen at times. And sometimes I do get bleeding from the head where I was stabbed. But still, there is no use. I don't see no use for me to go back to the clinic because at first, the right protocol and procedure wasn't followed. Another one, there was a time, actually multiple times, whereby I was infected by an STI. I went to the clinic. And then when I got there, because I already knew what was going on, I addressed the issue as to, okay, I've got an STI. And then the nurse said, how do you know that you've got an STI? I explained, and then she asked, upon her asking, she said, unzip, let me see. I said, it's not in my penis, but my behind. And then she was like, how can an STI be in your behind? And I said, I am a gay man. And then she was like, oh, wow, a man who sleeps with other men. How do you feel? I wonder, how do your parents feel about that? And I was like, because I'm bully as well. If you bully me, I'm going to bully you back. And then after that, I explained, and then she was very fussy about it, but I ended up getting my treatment. It happened again that I have to go back now because my life is very busy at that given time. When I got back again, same story. Whereby now you okay, as a gay man, at the end of the day, I'm a man. And if you're going to use force against me, hell will break loose. You know? So yeah, I think attitude-wise, they need to work on that. Because it is our right to good health. And if they're the ones who are pushing us away, where are we supposed to get that help? Because at the end of the day, you'll get another STI and be like, okay, I'm not going to go back there. And with my knowledge that I know, if you sit with an STI, once it gets to another stage, you might end up, I don't even want to say what's going to happen because you'll get rotten behind there. And then it leads to other health issues. Yeah, so I think they should work on their treatment and attitude. And they should know that when we go to the clinic, we're not there to be judged. That is why some of us don't go to church, because we are avoiding that. So I'm going to the clinic to get the help that I need, not to get a sermon that I didn't register for. Thank you.
Sanbono.
Greetings.
Ninjani.
How is everybody?
Yeah, anonymous please. Sex worker.
I'm a sex worker.
Ngihlala eBrakpan. Ngisebenzisayo iKing's Julius Clinic.
I use King's Julius Clinic.
Yes. Angiphathe kahle ngomsebenzi abangenzela wona khona.
I'm not impressed with the treatment that I get at the facility.
Ngike ngaba nenkinga ngavele infection la phambili because ngumuntu odayisela wonke umuntu esifazana besilisa.
I once was infected with an STI. I am a sex worker that is selling to both male and female clients.
Yeah, so kwenzeka kwapasta umsebenzi ngaba ne-rash ngahamba ngocela usizo bangijethi ngeke bakwazi ungisiza.
When I went to the facility, they told me that they cannot help me.
Because ngilala namadoda abo, ngilala nabafazi babo, ngilala ney'ngane zabo.
Because I have sex with their husbands, their children, and their wives.
So nga-end up manje ngizibuza ukuthi ngizosizakala kanjani.
I ended up wanting to understand how am I going to get assistance.
Ngabuyela khona kwesibili ngakusasa ngingasakhona ukuhamba.
Had to go back to the facility and it was now at a painful stage.
Ubhuti bekakumele angisize wangitshela ukuthi ngiyamfensa angisuke eduze kwakhe.
The gentleman that was supposed to help me said I am showing interest in him and he's not going to help me, so I should just move away from him.
Nga-end up ngiyeke indaba zamakliniki angisayihamba ikliniki and angiboni ngizophinda ngikwazi ukuyihamba ngendlela abasiphatha ngayo.
I then stopped going to the clinic and have made a decision that I'm never going to use a clinic ever again because of the treatment that we get when we're there.
Ngingajabula kakhulu iRitshidze mengasiza ilwisane nama-rights ethu siphathwe kahle nathi endaweni saziwe ukuthi sabantu.
I would really appreciate it if Ritshidze were to help us so that we are respected and treated in a human way whenever we go to health facilities.
Ngiyabonga kakhulu.
Thank you. Number 1. Okay, we're done.
Good morning, everyone. My name is Lutando Sono. I am a KP organizer for Eastern Cape. We now move on to our second group of issue, which are on safety at the facility. The majority of key population interviewed did not feel safe and protected from verbal or physical abuse, verbal or physical harassment, or risk of arrest at public health facilities. Only 14% of gay bisexual men sleeping with other men, 10% of people who use drugs, 19% of sex workers, and 14% of trans people felt very safe using the facility. For those not getting health services anywhere, a lack of safety was the major reason given by 26% of gay bisexual men sleeping with other men, 25% of people who use drugs, 30% of sex workers, and 27% of trans people. Of respondents using drop-in centers and mobile clinics, 27% of gay bisexual men, 23% of people who use drugs, and 23% of trans people reported unsafe conditions as one of main reasons for not using public health facilities. Similarly, only 13% of gay bisexual men sleeping with other men, 8% of people who use drugs, 19% of sex workers, and 15% of trans people felt comfortable at the facility. One trans woman told us, "I am not comfortable in that facility at all. And when I am not comfortable with the staff, you are not able to open up and tell them exactly what is wrong with you because you are afraid of being judged." And one person who uses drugs said, "The nurses look down on us. They say that we chose this life, which makes me feel uncomfortable to open up to them. If key populations are feeling too unsafe or uncomfortable to disclose they are key pops, it means they may not be able to gain access to critical or specific services where available." Ritshidze data highlights that a significant number of key population do not think that privacy is respected at the clinic, having increased significantly from last year's report. People we spoke to were concerned about ongoing privacy violation. For example, clinic staff were known as to disclose people's HIV statuses or the fact that they are queer, trans, or sex workers, or someone who uses drugs, to disclose HIV statuses in front of other healthcare users, or clinic staff invite other clinicians into private consultations in order to mark or judge people's symptoms. Services provision must respect the privacy of people as enshrined in their Patients' Rights Charter. For those not getting health services anywhere, a lack of privacy, one major reason given by 53% of gay bisexual men sleeping with other men, 38% of people who use drugs, 47% of sex workers, and 44% of trans people. Of respondents using drop-in center and mobile clinic, 47% of gay bisexual men sleeping with other men, 35% of people who use drugs, 41% of sex workers, and 35% of trans people reported the lack of privacy as one of the main reasons not given to using public health facility. In order for the key population access health service and a particular key population services, spaces are needed that feel private enough to disclose you are a member of key population group without fear your privacy will be violated. This will definitely require fixing many privacy concerns that have been reported. We will not reach national HIV targets or a country constitutional obligation without addressing this. We now move to recorded stories.
Ke berekisa clinic ya Impilation clinic. Then for my side, I'm not happy about the services still already raditola ko teng, especially for the community members like Borona, so especially the SMS. We don't get our own privacy there, especially when it comes to the problems SK people. We don't, if ever get something like problem here, STI or the other things, we don't get our own privacy or the comfortable people that we can talk about Libon, because I think they take our own, but like the problems that then they make it jokes. So we are not comfortable altogether. No, nante ke batla bana re itshintshile ke batla re treatwe as batho kaofela re tshwaneng le batho ba bang. The more people ba fiwang the best treatment ko clinicing le rona we deserve it because le rona re batho re batla more changes ke gore even la ba ra retsa go nna my wish nka re ka nna le ko tleliniking ka okay this side ke berekang ka batho ba song then this side ne ya batho ba song so more it's gore more comfortable we can talk anything re batla go ibua if ever there is something mo body yaka ke batla go e show off go then ke gona nna more comfortable ke ne relaxed so then I can show the problem e tleng ka yona gore problem e tleng ka ene ke ye ke ska ka tshaba go tlhagisa dilo tse ke tlang ka tsone
I ke batlong gore ba e adopt is that they have to respect, because LGBTI people, they are human beings, Libon, okay? So banality issues. It's not like if you are in LGBTQI community, you don't have problems, you don't have mental health, you don't have those kind of things that a human being could have. So they have to treat each and every one as the principal said, yes, so they have to treat each and everyone based on sexuality, based on what, but equality has to be there.
Dumelang bomme le bontate. Le kae? My name is Mokhetle. I'm from Bloemfontein in Free State. And the clinic that I'm using is Heidedal Clinic at Belinomi Hospital, the regional hospital. Clinic ya Heidedal.
The Heidedal Clinic
In Alabotat.
has a lot of problems.
Ke khona ho kena clinicing at 5 o'clock. Ke be ke tlo tswa ka 4 o'clock late.
I walk into the clinic at 5 a.m. in the morning and leave at 4 p.m.
Ke khona ho kena clinicing at that time ke sebedise transport ho palama. And then ke khutla ke sa fumana thuso.
I use transport to get to the facility and I come back home without being assisted.
Meaning I have to come back tomorrow again. And I'm using transport. When we try to talk to them, they don't want to listen us. They said we are here and we will wait and we will wait up until we get, because the treatment that you are coming to collect is ours, not theirs. Last few months after you helped me, I got a problem of the medication. Remember, we went there, get 2 bottles. They never gave me the other one, even today. But thanks God, because I went there and took a transfer to another clinic. I'm crying about the attitude of the sisters in the clinics. The attitude, my comrades, the attitude. It's very poor. That is why we gay people, we are now getting afraid to go back to the clinics. Because when you get there thinking that you are going to get what you deserve, you come crying outside. So please, let's help our sisters to be friendly to us. Heidedal Clinic doesn't even have maybe the lubricant. We struggle to get lubricant. We struggle to get people that can help us while we are gay people, lesbians and others. I don't know why. Myself, as I said yesterday, I'm lucky because I'm the member of TAC. So when I go there, I fight for myself because I know my rights. But what about those that don't know what to do when they are in the clinic? I had to fight for themselves. So I become a victim in the clinic because of doing that. Thank you.
Anonymous, morning everyone. My problem with the facilities is that confidentiality. I recall I tested 2021, tested positive. I went to school on March. got a call from my mom telling me that a caregiver is home, saying that I must come and take my treatment, which she disclosed my status without my consent. And I didn't tell my mother because I wasn't ready at that time. So my main point and problem is the confidentiality and the fact that they do not distribute certain treatments to the LGBTQI community. Thank you.
Public or anonymous?
Sanibonani.
Greetings.
Njani?
How is everybody?
Ngiphila. Ngeke ngahamba ngaye clinic like ngine rush.
I went to the clinic because I had a rash,
But usizo ngithola khona. In fact, azange ngithola usizo at all.
but I did not get any form of assistance.
Because from the main gate, from the security, bangibuza ukuthi ngizoyenzani.
Because I was asked by the security guard why I had come to the clinic.
And then mang approach I mean interest as clinic. And then mang vela it's like I think bayangazi or kanjani. And then mang chaza ukuthi okay ngine rush somehow, and then bangitshela ukuthi I have to go back to Ritshidze or go take angithi siyabapimpa bazokwazi ukusisiza.
So as I approached the main entrance of the clinic, I was told, even before I had spoken what my reason for coming to the clinic was, that I should go back to Ritshidze or TAC because we tell on the nurses what the work or the bad work that they do, so they're not going to help me. I should go tell Ritshidze or TAC.
Yes, so ngicela ukuthi ngala ku mhlambe Ritshidze or take mhlambe uyongasiza because basamsetshela uTake last baceba khona. And then okay, secondly ngaphinde ngabuyela first like I was feeling dizzy. Mangifika clinic okay they do ama checkups but zange bazi bawenze wonke, and then at the same time ngitshela ukuthi abanayi folic acid ngihambe ngiyithengele chemist. Mara ibe ngiyibona pharmacy khona.
So I went back the second time where I was feeling dizzy, and they did a few tests, they ran a few tests, and eventually told me that they didn't have folic acid, meaning the issue that I had needed me to get folic acid. They told me they didn't have it, but I had seen it in the pharmacy.
And then and then I got back to the third time again. By the time being nama piles, I went to a clinic and then ngifika bachazela, and then amanesi abizana wonke bathi because anizobona usesiputilo la namadodi ukuthi uvelini akabuyele ka take wakhe azokwazi ukumsiza. So
there was another instance where I had hemorrhoids, went back to the facility, and instead of them assisting me, one of the nurses called all of the other nurses to say, here's that tech comrade and Ritshidze comrade, the one that sleeps with our men is now here with this issue.
So my main concern is ukuthi angazi kanjani because ama sisters ama clinic abanawo ama private and confidential nama patient. So ukuze sibambisane nabo because angeke ngithule uzongitshela amagama abhlungu nami ngizoreply back kabi. So
I don't know how we can be assisted, but the nurses give us such a bad attitude that it comes to a point where we are unable to contain our own behaviors towards them.
Yeah, so ngalo ngicela ukuthi mhlambe Ritshidze to take asisize bazama ukubambisana because at the same time noma sugula or something sesasaba ngema clinic because uye ekseni ubuye ntambama, which means for the whole day uhlala lu-0 ekugcineni uthola ama disappointment namagama abhlungu.
So I ask that Tech and Ritshidze continue to help us reach a point where ourselves and the nurses can work together, because when we're sick and needing assistance, we need them to be able to help us and avoid having a situation where we exchange bad words amongst each other. Number two. Anonymous, right?
Ngiyababingelela bonke abaserumini.
Greetings to everyone.
Ngokukhethekile ngibingelela ama-sex worker nama-P-words.
But I would especially like to greet sex workers and people that use drugs.
Cebo Anonymous.
Yes, you are.
Okay, so ngiyacabanga ukuthi kwakuyi last year between mhla 6 September ngiye eclinic, mina ngihlala eDurban eHammersdale.
I'm from Durban in Hammarsdale, and sometime last year around September.
Yeah, it was the 5th or the 6th. I can't really remember the date. So mangifika eclinic, kama le clinic iHlengisizwe clinic.
The name of the clinic is Hlengisizwe Clinic.
Yes, so ngase ngiyacela ukuthi ngicela nje ukubonana ne-LGBTQIA nje personal.
I requested to personally meet the OBGYN.
Yes, kodwa before that like ngalandela wonke ama procedure khona. Yabo. So mase ngifika kudokotela ke mina ngile nhlobo ukuthi mayifika kudokotela ngiba transparent kuyona. Ngoba ngisuke ngifuna usizo ngempela, ngisuke ngifuna ukuthi enze itarali like angasrope ngikwazi ukuthi ngithole lonke usizo engilidingayo.
prior to myself requesting personally to see the OBGYN, I followed all processes and procedures. And when I came across the doctor, I was completely honest and completely transparent about everything because I wanted them to be able to help me with my problem.
Yeah, so udokotela waye umuntu wesilisa. Ngamthemba ke kodwa ngoba phela udokotela ukufundele. So ngase ngiyamtshela udokotela ukuthi ngi experience ini, ngamtshela ukuthi ngicabanga ukuthi ngine STD. Ngamtshela nje ukuthi futhi ngiyi sex worker yabo ngoba ngangifuna ukuthi nje azi yonke into, transparency njengoba ade ngisho.
I disclosed to the doctor that I am a person that is a sex worker and explained that I assume that I have an STI. This was a male doctor and I trusted him because he's trained for this profession.
Yeah, so uma uyi sex worker ke nje uba exposed ezintweni eziningi. Uyahlangabezana nama drugs, uyahlangabezana ne judgment yabantu, uyahlangabezana futhi ne violence. Yabo, so semhlabeni kahle kahle nje o dangerous.
As a sex worker, this is a profession that is very dangerous because you come across a lot of issues like drugs, people that are violating you, and any other issue that could potentially be dangerous to your life.
Yeah, so ngiyavuma ngagcina nami sengwadla ama drugs. Yes, so ma ngifika ekudokotela, udokotela ngiyamchazela yonke into engiphethe. The next thing ayenza udokotela uthi ngangibona mina inkinga yami uthi ayikuphi. Like it was the second day experience like ukuthi ngiyabona ukuthi la shooting ni STI and it was on the outside. Yes, so udokotela yena ngafile ngathi mina wangiviolate ngoba manje wa inserta umuno wakhe wonke ngaphakathi mina kwi private part yami yabo. And ngendlela enza ngayo it was like why pleasure-ish and ngaba shocked ngoba angifuna uqamba angibanga traumatized, ngaba shocked.
Yes. So how the doctor examined me felt like he was pleasuring himself, and that shocked me because I was surprised at what was happening. I wouldn't necessarily say I was traumatized, but I was shocked at how the doctor decided to run the examination that they were doing, because it was to a point where he almost had his whole finger inside of me, whereas the area that was infected had an obvious and outside type of STI side effect or
yes. So ngase ngisashocked kanjalo ngase ngiyavuka embedeni ngahlala ngezinqa ngambuza ukuthi awenzani yabo nje ngokuphoxeka ukuthi hayi kwaze kwangafana now since you are a doctor yabo. Yeah, so ngamtshela ukuthi ngizomreporta, angiyithandanga lento ayenzile, ungiviolate nje ngayo yonke indlela yabo. Wangitshela ukuthi kuyafana ngiyini mina, I'm just a mere sex worker, akekho ozongikholwa. Uba ungakholwa sex worker nomuntu ogqoke ijazi elimhlophe elide wafaka nalezi zinto zabo abayifaka emqaleni zokulalela.
So I in the process of the examination happening, I set up and explained to the doctor in a disappointed manner to say I didn't expect this from him, because as a doctor they were supposed to help me and not violate me because I feel extremely violated. His response was that nobody's going to believe I'm a sex worker over a qualified professional person. And I was particularly disappointed in this from a person who had gone to school to be able to help us.
So ngoba inhliziyo yayiphakelwa ngaba angry nami, kwakukhona iobject nje eyinsimbi kodwa eyisebenzisa yabo khona lapha erumini yakhe. Ngenxa yokuthi inhliziyo yayiphakelwa ngagcina sengithatha yona leyo nsimbi le, and it was sharp engamlimaza ngamshanga ebusweni because ngangifile ngathi uyangihlukumeza ngalento ayenze ngoba mina ngangithi ngiyakuyena ngiyofuna usizo futhi ngimthemba.
Out of anger, there was a metal sharp object that was next to me, and I took it and almost stabbed him in the face with it because I didn't expect this from a person who was supposed to help me and not continue to violate me. This was a safe space for me, and the doctor completely took that away from me.
Yeah, so after that ngase ngiyahamba ebhedlela ngabhala notes, ngase ngifaka lama suggestion box la ama complain. Yes. Ngafaka lapho icomplaint yami ngabhala ngisho igama lakhe lo doctor. It's a pity ukuthi angisalikhumbula igama lakhe. Ngabhala ngacomplaina ngakho konke akwenza kumina, but kwangaba khona nje umnyakazo ngase ngicela umphathi wesibhedlela i superintendent ngaqale ngabuza ukuthi ikhona yena umphathi wesibhedlela bathi ukhona ngase ngabuza ukuthi ngase ngiyacela ukuthi ngingakwazi umbona baqhaye bangibuza kuqala ukuthi ufuna ukumbonelani.
So I wrote my complaint down, included the doctor's name. I unfortunately right now cannot recall the name, but nothing came of that. And in the same breath, I had requested to see the person who was in charge of the hospital and or the facility, where I had to first explain the reasons that I wanted to see the manager for.
Yeah, so mase ngisho ukuthi sengivelelwe into ethile lapha ngize kudokotela wangiharasa ngalendlela angiharasa ngayo. Manje ngifuna ukubona umphathi wesibhedlela, ngifuna ukumreport, sengiyibhalile neletter lapha ngayifaka kwi-complaint box. Kunalokho ukuthi bangivumela ukuthi ngihambe ngiyobona umphathi wesibhedlela, bangitshela ukuthi hayi umphathi wesibhedlela akulula ukuthi umbone, ufuna uqale wenze appointment.
They denied me the opportunity to meet with the management, the hospital management, and said I had to first set up an appointment, even after I had explained to them my reasons for wanting to meet with the manager.
So ngabona nje ukuthi yazi lento eyishort le dokotela ukuthi they would never believe a mere sex worker over a qualified doctor, ukuthi mhlambe wayiqinisile ngoba ngabona nje indlela abangafunanga ngayo ukuthi ngiyobona umphathi wesibhedlela after sengibatshelile ukuthi udokotela wenze lokhu nalokho. It was like ni staff naso sasim protector udokotela.
I felt as though the people that were supposed to direct me and guide me to the manager's office also protected that doctor and hindered me from being able to access my rights and report this case formally. I felt as though what the doctor had said about a mere sex worker not ever going to be believed over a professional person was actually a true reflection of the current world that we live in.
Yeah, so ngase ngishiya kanjalo ke njengoba ngabona ukuthi into engeziye ndawo. So ngase ngiyabona ukuthi ushuthi umuntu ngoba nakho ekhetha ukuba transparent kudokotela shuthi kuzowenzeka lento njalo emaclinic mangiya khona. So fortunately ngahlangana nomngane nami to Qiniso Ndlovu. Thank God for Qiniso Ndlovu ngoba wangitshela ukuthi kunenye iclinic ese Morningside eDurban ya TB HIV care, wangitshela ukuthi khona nane Bellhaven Harm Reduction Center provider ama drug addicts ngemethadone mayesefuna ukuyeka. So ngakwenza nangempela with no doubt ngamane ngamkholwa nje uqiniso angazi ukuthi yini yathi ngimkholwa.
So I blessed Qiniso, whom is a person that I met and that assisted me by directing me to another facility that is called HIV and TB care, where I was then able to be referred to get methadone, and I, without a doubt, followed all processes and procedures and was able to get help from those facilities.
Yeah, uqiniswa ngitshela ukuthi le clinic ese Morningside idila nama sex worker kuphela. Mase ukuthi Bellhaven Center la ila ngingakwazi khona ukuthi ngiphume ema drugsini uma sengifuna ukuphuma ngoba bayanikezana imedication ukuthi uyeka uqeda ama cravings nakho konke lokho. So ngiyambonga uqiniso, may God shower him with blessings. Yabonga.
So what Qiniso had done was refer me to two different facilities, where one was specifically working with sex workers and the other was specifically working with drug addicts or drug users that wanted to stop using. And I really bless Qiniso for everything that he has done for me. Thank you.
Okay, so recommendations. The Department of Health should issue a circular in February 2023 outlining that a key population should never be refused entry to public health facilities or refused access to healthcare services. B, that all key populations should be treated in a friendly and dignified and respectful manner, and that privacy violation, ill treatment, harassment, and or abuse will be met with consequences. This circular should be clearly explained to all clinical and non-clinical staff, including security guard and respective security guard companies. Urgently investigate all reports of poor staff attitude, privacy violation, verbal or physical abuse, harassment, reports of services being refused, denied, and ensure consequence management take place. A full breakdown of facilities of facilities will be provided. For facility, we report on the National Department of Health should respond within 3 months with actions that have been taken. The Department of Health, the Department of Health should work with PEPFAR to ensure that all clinical and non-clinical staff, including security guard and security guard companies, are sensitized on provision of key population-friendly services before the end of COP22. Key population must be involved in the implementation of these training modules. Post-sensitization training, work with PEPFAR to complete follow-up assessment to check the quality of key population services provision at site level to show the success of sensitization program. Work with key population to develop posters and then distribute all sites to improve overall sensitization of facility, staff, and community members. Hire more key populations in facility, intentionally encourage and support key population to uptake education and training to become healthcare workers, ensuring more clinical and non-clinical staff are key populations will improve overall sensitization efforts in the long term. Facilities should be held accountable to always provide friendly, respectful, and confidential services to all key populations. Use signs to show if consultations rooms are in use. Staff wishing to enter should knock and wait a response before entering. Consultation should pause until the additional staff member has vacated the room. Hold dialogue sessions between key population and clinic staff to sensitize staff on key population. Support key population-led health talks at facilities and key population awareness days to sensitize general community on key population issues. Display clear posters on key population services, rights, and general sensitization. PEPFAR should provide a full list of facilities by end March 2023 where district support partners have trained and sensitized staff on key population, including how many clinic staff, including security guard, have been trained per site. Work with the Department of Health to ensure that all clinical and non-clinical staff, including security guard and security guard companies, are sensitized on provision of key population-friendly services before the end of 2022. Key population must be involved in the implementation of these training modules. Post-sensitization, work with the Department of Health to complete follow-up assessment to check the quality of key population services provision at site to show the success of the sensitization program. PEPFAR should, in COP23, fund key population peer navigators at all PEPFAR-supported sites, especially at key population designated sites. In COP 2023, fund KP-led community groups to carry out training and social mobilization on treatment and prevention literacy and the rights of key population in the healthcare system. In COP23, fund a nationwide hotline for key population to report via SMS, call, a WhatsApp, or please call me about poor treatment, discrimination, and abuse for follow-up corrective actions.
Thank you, Chairperson. Next, we will look at key population-specific services at the facility. As is well documented, key populations are disproportionately affected by HIV. It is therefore critical that key populations can access specific services to meet specific needs. Monitoring of Ritshidze sites from October to December 2022 reveals that a low proportion of facilities provide services for key populations when asked generally. Just 33% of facilities reported providing services for gay, bisexual, and other men who have sex with men, just 30% for people who use drugs, just 26% for sex workers, and just 21% for trans people. 205 of the facilities monitors did not report offering any services for any key population group. However, when probed further into the specifics of what services are provided, it is clear that very few facilities have any specific services needed. So out of 356 facilities, only 119 said they provided services for gay, bisexual, and men who have sex with men, but really this was fewer. For example, only 27 offered gay, bisexual, and men who have sex with men outreach services, and only 62 offer lubricants. 261 had no services at all for gay, bisexual, and other men who have sex with men. Or out of the 356 facilities, 107 said they provided services for people who use drugs. However, in reality, out of those sites that say they offer services, only 39 offer referral for methadone, 2 offer drug dependency support groups, and only 9 offer new needles. 273 had no services at all for people who use drugs. Or out of the 356 facilities, 92 said they provided services for sex workers. However, in reality, only 62 offer sex worker-friendly HIV testing, only 16 have outreach services for sex workers, and only 30 offer gender-based violence services. 270 had no services at all for sex workers. Out of the 356 facilities, 76 said they provided services for trans people. However, in reality, only 29 offer contraception, only 8 have outreach services for trans people, and only 23 offer psychosocial support. 287 had no services at all for trans people. While the Department of Health and PEPFAR have committed to establish 1 center of excellence per district, this remains inadequate to meet the needs of key population. A minimum package of key population-specific services should be made available to meet key population-specific needs in at least 2 designated public facilities per key population group per district. In addition to providing a minimum package of services, these facilities must be highly sensitized to the needs of key population and providing friendly, safe, and confidential services. Where key populations need specialized care from one of these health facilities, easy referral and adequate resources, including planned patient transport or transport cost, should be provided to ensure that people can actually uptake these services.
So next we will be looking at the availability of condoms and lubricants. Key populations often struggle to access basic prevention tools like condoms and especially lubricant, either because they are simply not available at all or just because they are key populations. They are questioned for taking them or refused access. Ritshidze data gathered in 396 facilities show that lubricants were only freely available in 27% of sites. External condoms in 81% of sites, and internal condoms in 65% of sites. Data collection among gay, bisexual, and men who are sleeping with other men and sex workers found low availability of external condoms as public health facilities, with only 63% of gay, bisexual men who are sleeping with other men and 77% of sex workers able to access external condoms, and only 50% of gay, bisexual men who are sleeping with other men, and 55% of sex workers who could only access external condoms, saying that they could get enough, which raises a question of what about the other percentage of people, they are not getting condoms. Only 45% of gay bisexual men who are sleeping with other men, 40% of people who are using drugs, 53% of sex workers, and 59% of trans people using public health facilities said that they could access lubricant. And only 50% of GBMSM, 40% of people who are using drugs, 56% of sex workers, and 64% of trans people using the public health care facilities said staff were respectful when they tried to access lubricants. And among those who could get lubricants, only 48% of gay bisexual men who are sleeping with other men, 31% of people who are using drugs, and 48% of sex workers, and only 59% of trans people using public health care facilities said that they could get enough of the lubricants. Comrades here today, please put your hands up if you can regularly find lubricants in your clinics. Can you guys find lubricants in your clinics? Thank you. That's the reality. Not everyone can access this basic commodity in the clinics. They are always not available, or they just have run out of stock. Condoms and lubricants should be available at facilities and can easily be placed in the toilets and other quiet places over the clinics where people could take them without the fear of being seen and judged by others or being told to put some. But we only find a few lubricants, and they are put in the front there where everyone can see you, and you'd be scared to take those lubricants. Now we move to recorded stories.
Loko clinic o batla condom o batla lubricant. Condom wa ikriya, condom di clinic di teng di condom, okay. Mara lubricant ke problem, batla go bolela ba re no re dira pap smear ka di ka tsone. Ka di lubricant. So a ba go fi lubricant. A ba go fa lubricant ba go botsa e le go lubricant go dirang ka yone. Hey, no, I'm gonna use it hare va nna le motho. But yo what's about Vaseline is something that's very oily. Okay, I know I prefer loop. No, loop rona ga e berekisa. A batla go dira eng, a ba sa di batla go dira pap smear re bereka ka yone.
Ngizokhuluma ngama-clinic ayi-2 ikliniki yasemasi nase number 2 defanteni emanaleni. Iproblem yeloop yethu iloop sithola kanzima kakhulu because iloop amele uconsult. Noma ngafuna uconsult must be uconsult. One, because nabantu abangabereki my sister banga afford ukuthenga iloop eclicks. We have to get iloop kuphi eclinic. Then after that clinic we have to consult. That's a problem. I feel bad because of now. Wonke umuntu ungibhekile ukuthi okay. Angibangitshela in public. Kuthi mafune loop consulta. Abaye bangilalela ngafuthi okay this person ufune loop. So it's gay or it's what? You understand? Yes.
Kiuza clinic ya nikiuza ya Majaras Pap. Then bekishifte ko Majaras Pap kiuza kana clinic. The challenges tsa ke gore ko Majaras Pap like ne ga se go la ka lubricant. And then last night ke tsamale one of my friend ne re le ko teng ena la bothata ba di pulse. So berea ka se name o se bateng. Then berea a re fitla ko teng ko re fitla re kena be ke bolela sister because it's my friend. Ke bolela sister okay tshumi ka bothata bo so na tshaba o bua. Then o se teng ba re eya ke go dula le diriwa yana. Kamatete le se eng be ke mola ke ro ka se re yalo re tlile monana wa ile se re feed lubricant because batho ba ora bola tsama no itse batho di tlisa so ha re tla mo tla go bua hadi batho ba di getse ding ha di fitla mo ba di grey okay ba re shiftela ka mo kana clinic still ba ntse ke lona di lubricant a lona di lubricant re kopana le sister o mong again that time no kulanna and by then about okay I get a local in this guy lubricant while is using my data alone because they try to use my data alone. I was like oh okay yeah ba ke ko clinic no next I feel comfortable because if it's all like o ka se buile patient yalo ke feel or can understand okay like LGBT people but then I get And while ba le teng, they have to ba re treat ka the way ba tla ba treat ka teng, not special but simple. Yes. Yeah, ke feel so small, ke feel like sister one disrespect while nna ke mo respect and I can respect mosebetsi wa hae. So ke feel like there's no need ya gore ke nne ke go clinicing ke lo batla dintho ke di batlang because of ha ke di kry after all. Kampa ke ya go clicks or somewhere ke lo ithekela tsona because for free sa government ha ke di kry akere. Hona re na center as where the LGBTQI community can open up for themselves and then share the stories with them. So the problem is that we don't have a safe place whereby we can share each other's stories. And then lubricant is one thing that is a major problem to us as the LGBTQIs here in Kanana Okni. And then other than condoms and whatnot we do have. But yeah, there's only the challenges that I have or the other communities have. They treat me well. And but about holidays whereby I understand, okay, there's this sexuality is a halang, mobupilong, so they have to accept. So other than this, I don't have any challenges based on my sexuality. Yeah.
As a sex workers, clinic, e beye di condom mo pele re itle re itsele the way re batlang ka teng. O sa butsiwa gore o tla irang ka di condom, o tla irang ka box ya di condom. Kopa hela re tsena mo clinicing, re itsele or re be le someone o tla re understandang language ya rona. Gore wa itse keng condom e thuegile or ke rapeile gore a kgone go ba sentle.
Greetings.
Orange Farm.
I come from Orange Farm.
Complaints clinic Orange Farm.
I have a problem with the Unit 7 clinic in Orange Farm. They don't assist people that use drugs properly. They return us. We don't even get the opportunity to get inside the facility. The security guards return us from the gate. We cannot access treatment anyway. We are not even offered methadone. We would like assistance in that regard. For at least that we can get methadone. And for us to be allowed to access the facility and get treatment or any other pills that we might need.
Thank you.
Hello everyone, my name is Don Wampofo. I'm a transgender man. For me, I'm having a problem at the clinic of misgendered, and they will call you fraud. I remember the time that I went to the clinic with my kids. They said I must produce my ID. I don't know if you are a trans man or a man is not allowed to take the small kid for vaccination. So when I take my child to the vaccination, and the nurse was like, she was so rude, and she was asking me questions, and she ended up asking my kids, and I feel like my kids were traumatized because they end up asking my kids, do you know this person? Who is he to you? So in other words, I gave birth to them, and I've got the right to take my kids to the clinic, regardless of me being a transgender man. So the time that I went there, they started firing questions to my kids. They take them to a private room. Then I asked them, why are you doing that? Because the fact that I'm transgender or what? They said we are suspecting fraud. Then I said, no, you can even see that I end up taking off my shirt so that they see all the surgeries that I did, because like I felt I don't know, like after that, I went to look for a psychologist so that I can get help. So what I'm crying for, if the service providers, if they can give us people who understand us as trans community, if there is inclusion of trans community queerness in all clinics so that they understand us more better than anybody else. Because now my kids are traumatized, I'm also traumatized. Like at this moment, I think there's an immunization that is going on for the kids. I can't take my kids to the clinic because I feel like if I go there, they're gonna fire me with questions. What is gonna happen to my kids? Because the nurse end up saying, "So how are you? How are your kids taking you? Are they calling you daddy? Are they calling you mommy?" And all those things. It's now traumatic to my kids because to them they understand me more than anybody else. So what I'm crying for is inclusion in the public spaces. If we can have the services by the public clinics, they know that transgender are there. And we only have one trans clinic here in Joburg, and we can only find it in Joburg. And for me to travel from Bronkhorstspruit to go to Joburg, I can't. So I'll end up just go to the pharmacy and say, okay, I'm sick. Pharmacist, can you give me pain tablets? Because I'm afraid to go to the clinic. So all we are asking for, if ever we can have these services that we are getting at trans clinic by the public clinic. Thank you.
I would like to greet everyone. Guys, today, as I was going to be talking about my problem that I was facing at the clinic. The clinic that I was going to, it's at a Sizwe clinic, apparently where I was staying. It doesn't work that time, guys. And from that time when I was there, I used to go to the clinic. And by the time when I was going to the clinic, the first problem that I was even meeting, see by the security at the entrance gate. And they will ask you, what are you coming here to do? And then at that time, I wasn't right at all because I was sick. I was having TB. By being an addict and then smoking heroin, it was affecting me because I was not even able even to breathe properly at that time. And by the time I was going to the security, even talking to him, explaining to him that, hey, I'm going to see the nurses inside because I need to check myself because I don't know what is actually happening to me. Because at that time I didn't even understand what was TB. And because of staying at home and not knowing what was happening to me, when I went there to the clinic, the first thing that they asked me, hey, are you really sure that it's TB that you have? And then I told them that, no, I didn't know that I was having TB. But what was happening, the symptom that I was seeing, coughing blood, sweating, not even able to sleep in the night, I think it's TB. And then what they were like saying to me was, telling me that, hey, are you really sure that what you're saying that it is TB? Because of all the time we used to go there, they don't even like study even to test us, even nothing, even to give the flame. And I never even do even all that, but keep on like going there all the time, not even not even giving me time even to talk to me. Even the nurses, even though like they were even doing, you see, like as we were sitting like on the chairs, they won't even like spend even not even a single time, not even to ask you what is your problem that you are facing the time. And then as for us, and as we were always saying that,
That? Yeah, we don't know what's happening, but we'll give, yeah, maybe it's just a hit, we're not sure. So I think they will take care of him and let's continue with the program.
Sanbonan, kama
Greetings.
Mutsepiso, Mbuya Eval.
Sidibeng. Okay, mina inkinga yami ukuthi ngi-lesbian. So I was raped when I was 12, and then I discovered when I was doing grade 12 that I'm sick. So I went to the clinic. Okay, public. It's
No,
okay.
okay. So my name is Tepiso. I was unfortunately raped at the age of 12, and at the time when I was doing my grade 12, my matric, I found out that I was sick.
Okay, and I went to Mpilisweni Clinic at Zone 7. So I started my treatment there. So every time when I was going there, I had to explain myself that I was raped. And yeah, every time when I'm going there. So eventually when you go to the clinic, today you see this sister, tomorrow you get another one. So you have to always remind them that yes, I was raped and I got infected. So the only thing that bothers me is they will ask you stupid questions like, how can you get infected while you're a lesbian, saying you don't sleep with guys? So you have to start afresh. I was raped. That's how I got infected. And then the thing that bothers me is that you stay too long in the queues. Sometimes they cut the line, say you come back tomorrow. So I decided I won't go to the clinic. I started defaulting. I think I took a year not going to a clinic. And then I switched the clinic. I went to Beverly Hills Clinic. So I started there, and then I had to go start afresh. Then I got tested. Like I was hearing myself, I was coming weak. So I went to the clinic, I started fresh, get tested, and same story again. So you're a lesbian, you infected, that's how you do, guys. You drink alcohol, you move around with guys. When you're drunk, you're sleeping with the boys. And I'm like, no, I don't sleep with boys, and I never sleep with a guy. I was raped. So I guess you'll never get past through the thing that you were raped. It will always reflect to you that you are raped. But otherwise, I think tech, because last year I joined tech, so we're monitoring in the clinic. So now when I go to Beverly Hills, they will say, come fast, check your medication, and out. They don't question anything. Thank you.
Next, we will look at the PrEP and PEP availability. PrEP is a vital tool to support HIV prevention, especially among key population who are at high risk of getting HIV. And positively, it is available at 99% of 400 facilities regularly monitored by Ritshidze. However, despite this, Ritshidze data shows that PrEP is not always made available to key population in the facility, and lowest for trans people. PEPFAR says that PrEP is actively offered to everyone who is eligible and wants it. However, our data shows major challenges in this implementation of comment. Only 73% of gay, bisexual men sleeping with other men, 40% of people who use drugs, 71% of sex workers, and 75% of trans people we interviewed had even heard of PrEP. Many people heard about PrEP for the first time from us. As one sex worker said, no, they don't tell us about PrEP. This is the first time I am hearing about it. And from how you have explained it, this is what a sex worker should be on because of the risk of our job. While covering a wider and different set of sites, only 28% of gay, bisexual men sleeping with other men, 15% of people who use drugs, 28% of sex workers, and 27% of trans people interviewed reported being offered PrEP at the facility, pointing to the reality that while PrEP is sitting in the facility, key populations are not always made aware of or actually offered PrEP. PEP is not available. Only 41% of gay, bisexual men sleeping with other men, 50% of sex workers, and 50% of trans people interviewed reported having been able to access PEP when needed at the facility. Now we move to recorded stories.
Ke nna mo Klerksdorp. Ke tsamaya clinic ko Alabama clinic. So the services tsaka ke di kry-a ko Alabama. And then I'm a sex worker and ke visit a clinic now and then because of tragedy tse re kopanang le tsona mo tseleng. Sometimes condom ya thubeha. Condom e thubegile because ke bereka mosebetsi o so le o so. Ao, okay, wa tswa sister o tla bitsa batho ba bang. O le ena tlo go botsa o batla eng? Nna ne ke kopa di-flagelle sister gore ke clean condom e thubegile or ke kopa PPE. Or ke kopa PEP. Ha bana tsone. Ha re na tsone le lubricant. Hayo we sanga lubricant. Wa bona dipotso tse di yalo. So ke ne ke botsa gore go improve clinic ya rona. Ha gona go nna le bothata ha government o ka hira some of sex worker understand andilo tse tsa clinic gore re sa ba re tlhekefetsega ba bua ka rona ba bua le rona mo gare ga batho. Sometimes batho ba bang stigma a isitse fele because ha ba rate ntwe ya rona di sex worker ba re ke is a sin.
Good afternoon, everyone. I'm from Freedom Park Clinic in Devland. So in Freedom Park Clinic, we have a shortage of lubricant. Actually, we do not have a shortage of lubricants. They are not available at all. And every time we ask why the lubricants are not available, they'll tell you that it's either they don't have budget or they are on stock out. So it's always the same story. Thank you.
Good morning. Oh, good afternoon again. Or whatever. Okay. About the lube issue, I think it's a very big problem that we have, and now what I've noticed through the research that I keep on doing, I came to find out that it is not only the clinics that should be held accountable for such. Even the ones above, they need to make sure that the lubes are there and fully stocked. Because we'll blame the clinics. At the end of the day, there is little that they can do. Because they only give what they receive at the end of the day. And when it comes to lubes, I think it would be better that clinics are equipped with gay-friendly services so that it becomes easier for one to go there and feel comfortable. Because I think if they were very well educated when it comes to gay-friendly services, it was going to be better. They were not going to judge, I think. So I think it's lack of understanding. So if they can get training, as it said, you never stop learning. So you learn on the job as well. They can do better if we can learn to understand each other and learn from each other. I may be just a patient, you may be a professional, but only to find out that I can help you know something else that you don't know. All in all, it needs us as individuals to come together as one and realize one thing. We all human beings, and we all deserve to be treated equally, whether you're a professional or a patient. Yes, that's all. Thank you.
Thank you very much. For now, we'll be joined by the Deputy Minister Jomo. Would like to thank him to make time for him to join us online to respond to the report. Unfortunately, he had a busy schedule, but he made time for us. So without wasting any time, Deputy Minister, over to you. Deputy Minister. Yeah, maybe you need to unmute. Yeah, he has joined, I've been told.
Hello. Oh, my
Yes.
chair. I have been struggling to speak because it was saying the host is not enabling me to.
Okay, I think that technical problem is sorted now.
I am around Rondebosch. Oh, in the next minute or so, I'm going to be cut off until I pass this spot. I was wondering if you could just go through this patch and then speak again.
Okay, I think what will work for us, I think we need to just take 5 minutes break to stretch. And then when Dr. Sbongiseni Dlomo is back, and then we'll continue with him.
Yeah, 5 minutes will be excellent, my sister. Thank you very much.
Thank you. Thank you very much, dear. Okay, sorted. Hello, thank you very much. Let's come back. I just want to check whether the Deputy Minister is ready now. I think we have given, oh, yeah, he is. Sawubona Nkokeli. Welcome to the session. Now I will hand over to you.
Thank you very much. My sister, that I call is Shoshovu, who actually doesn't retire until all the programs of people of key populations have been sorted out. I had a small glitch. I was just landing in Cape Town, and they just needed to get out of the airport and be able to log in properly. Let me thank firstly Comrade Anele Yawa, who provided me with a report that has just been tabled, and some of the members have been alluding to it, which now my experience as well. And thank you very much for the hard work done under the umbrella of Ritshidze for actually collating so much rich data that actually assist us in this process. I hope, Chair, that our data will improve, but maybe it may stay this way anonymously, because for now it is showing us per province and in districts, and we are not able to say maybe at King Cetwayo it was mainly and Melmore and not so much Richards Bay or vice versa. However, we'll have to work with that data and say maybe our improvement also as a health department must be informed and be assisted by this data greatly. I have gleaned through the data and have seen that there are challenges in the country in terms of access to health services by our key populations. And we can only improve from this base. I want us not to retire and not get tired and say we'll continue despite these challenges. We might have not done very well in terms of training our staff and all our, and then when we are talking about the staff, starting as the report reflects, people at the gate, the security at the gate, before you can even get to the clerks, nurses, and doctors. So there's a whole host of teams that needs to be improved in terms of their support to the programs. I must hasten to say, I want to use another example, because as a Deputy Minister of Health, among other areas that I'm charged with is to really focus on support for the key populations, which is a topic that we have today. I have requested the department to involve and include a particular group of South Africans as a key population. That is mainly adolescent, youth, and young people. And let me motivate why. Because through dialogues like the one that we have here today, I've learned this from adolescent boys and adolescent girls, mainly adolescent girls and young women, to say, but Dr. Zuma, I am pregnant today. I would not have fallen pregnant if when I went to the clinic last year, the attitude of the staff was a friendly one, to say, yes, we noticed that you are 17 years old, and we want to commend you for being responsible and come and ask for a protective device against pregnancy, against sexually transmitted infections. Here they are. But I must report to the leadership here that we only have 1,900 clinics or health services in the country that I can now confirm are youth user friendly, meaning that if you walk into the clinic Willow Vale, for example, in the Eastern Cape, in Willow Vale, they can actually, there's a nurse who is trained to have services that are youth user friendly. Now, and the dialogue has taught us, the young people are saying, no, Patuladomo, don't give us a nurse of your age, because your age, you are a grandfather or you're a father. I can't go to you and ask for condoms and ask for lubricants and this. Can you really make sure the services for young people is provided by a young nurse? Now, leadership here, I can guarantee that it is only about 1,900 health facilities in the country that have got services that we can now confirm, at least in that clinic. If you ask for Sister Letiwe or Sister Gloria, that is a sister in that and that clinic who's providing that service. I therefore think, comrades and leadership, we need to use and piggyback on this same platform, because I have not been exposed to the module of what is actually being discussed here, as this is how big is the module, this is how long it takes to have this service, to have a population looked after in a friendly way, key populations. I hope that maybe I can plant this idea to the leadership to say, I would wish that why don't we maybe for a start target those clinics but some of them may not be in the relevant space where you wish, but target those clinics that already have got a nurse who has already got an improved attitude. To say, I'm not going to turn away a 16-year-old who has come to ask for condoms. I'm going to have a change of my own attitude first. Why don't we maybe target those clinics that are already have got such programs and add this module clearly? Because it will take a bit longer if we don't have targeted areas we can now be able to refer all our key populations members to say, maybe we think not the whole of the Eastern Cape, but at least if you talk about this one, and this one, those ones we have started this program, and at least those ones you are going to find a nurse or a healthcare worker who's youth user-friendly, who's over and above that, have an interest to support the key populations when they come for health services. And because that one nurse is able to influence the whole of that clinic, starting from the gate right until to the dispensary. So maybe let me pause there for now to say, I would want to suggest such an approach where we probably piggyback on this by starting to say adolescent girls, adolescent boys. I have termed them a key population on the basis that when they go and ask for services, there's a lot of us who have got attitudes to them and do not want to say, thank you very much, you are responsible enough. We need to say, this sex worker is so responsible to come and ask for condoms, because what I learned when I was in India, sex workers are saying, this is my sex work. I wake up every day and I support my children. Some of them are at the university. I don't want to die very young. I want to be there when my children graduate. So the only thing I do is to protect myself while I do my service. And I commend that is very responsible. So we should be saying as government, here is a group of South Africans, sex workers, who want to see their children off completing universities, who want to see their children getting all other dreams, and they want to be there. Let us support them to have a long and healthy life. A long and healthy life slogan is not available for Rudlomo and his friends. It must be for all South Africans, even those who come and ask for this service. Maybe let me pause there, my sister and the leadership. I don't know whether maybe you would want me to pause and wait for clarity-seeking questions or comments. Over to you now. Thank you very much.
Thank you very much, DM. Unfortunately, because of time, we can't have that dialogue now. I think that dialogue, we can have it when we have formal meetings. However, I think DM, before we continue, while we are still here, what you are raising is very important. And it's very supported, hence we are sitting here talking about challenges. As you are seeing the group of people here, this group of people are the ones that we are talking to or referring to. They are seeking for healthcare services, but at the end of the day, they don't access it. So the attitude that they've been complaining about, which is something that it's been here for years, I think we need to start there. You are right to say we need to get that healthcare worker who's doing well and recommend that healthcare worker and appreciate that healthcare worker. That's what we always do when we meet such people. But unfortunately, we don't have a lot of those people to acknowledge. And the clinics that we are supporting for now, these are the problems that we are still facing. But as Ritshidze and people living with HIV, we are really keen and still continue to want to work with the Department of Health, and the suggestions that you are bringing on the table are well received. So without wasting any time, I think we should continue with our program because it's too hot where we are. Yeah.
Thank you so much, Chairperson. Now we will look at harm reduction. Harm reduction services are critically important to support people who use drugs to stay alive and protect their health. Importantly, people who use drugs must be met without judgment. However, on the whole, these services are not available, and people who use drugs are often judged and treated in an especially hostile manner. Those who have tried to access harm reduction services are often left without services or any information on where they could get them. Only 6% of people who use drugs were offered information about where they could get new needles from the facility. Only 11% were given information on where they could get methadone, and only 8% were given information about drug dependency support. Services accessibility must be improved to ensure that people who use drugs' needs are met and no additional barriers are created to being able to take drugs safely or be supported to stop. We now hear from community members with us today.
Good day. My name is John Doe. So I had a young issue earlier in the year last year with particularly PEP. Life happens, so I had to go to the usual clinic I use, which is Davidson Main CDC. And well, let's say I had to jump through hoops. Literally jump through hoops. Load shedding's nothing like that. So first I had to explain what happened. I'm okay with that. Then I got cross-questioned as to why I needed, given I am a male. So according to my knowledge, PP is not only specifically for females. Anyone can be exposed at any given moment. So it is that whole conversation that I had with that particular nurse that was horrid, and I ended up not getting it at that particular clinic. So I had to move to a different clinic to get it. So my question is, how do you go about ensuring that they are aware that as a KP, this is what we have to deal with and this is what we are at risk of? They shouldn't make it difficult for me to access PEP. They shouldn't make it difficult for me to access PrEP, because it was that particular clinic. When I leave there, going to Crystal Park, it was a seamless process. So can that particular clinic be addressed, and that particular staff, let us understand, because it's not balancing. It is just not balancing, people. Thank you.
Sanibona. Yeah, ngibuya eDurban.
I'm from Durban.
Ngi-sex worker.
And
ngisebenzisa uPrEP.
I'm a sex worker who uses PrEP.
uPrEP engilethelwa iwona uTPK.
I access my PrEP
from mobile clinic.
I access my PrEP from a mobile clinic.
Ube nesikhathi la nginamaphilisi amancane. Kwacaca ukuthi uma ufika uTPK mobile clinic ngibusy neclient. So wazi wacaca ukuthi uze uyahamba ngingaphumi.
There was a time where I had a low number of PrEP left over, and I unfortunately could not make it to the mobile clinic as I was busy at work.
Ngase ngahamba ngaya eclinic eseduze ekuse-Eddington clinic. La engafika khona ngamtshela unesi ngiphethe necard ngasho ukuthi ngicela bangenzele uPrEP ngoba manje imobile clinic isize yahamba and amaphilisi amancane.
I later went to Eddington Clinic with my card that was specific as to say that I'm collecting PrEP. I requested the nurse to please assist me and give me the PrEP because the pills that I had left over were not going to last me a long time.
Unesi wangiphendula phambi kwabantu ababekhona wathi le clinic akuyona iclinic yabaqwayizi. Ufuna uPrEP wakho cela uphindele la ovela khona kwimobile lane ngoba nemobile lane yabaqwayizi la kuyona indawo yabaqwayizi. Sengibukanisa nabantu ababekhona lapho awuzange ungiphathe kahle lokho.
The nurse embarrassed me in front of all other patients that were at the facility at the time when she said the facility was not for sex workers. I should, as a sex worker, go back to the sex worker clinic, and that embarrassed me and didn't sit well with me.
So emva kwalokho ngahamba ngathola inamba yakhona ka-TBK ngafona bafika bazama ukuthi bafike ebusuku bezongilethela amaphilisi ukuthi mina ngeke ngisaphinde ngiye e-Eddington Clinic ngoba ngaphatheka kabuhlungu.
I later managed to get the contact details of the mobile clinic and I called them and they actually came to me late that night to give me the pills, but I would never ever go back to Eddington Clinic because of the treatment that we received when we were there.
Next, we look at gender-affirming care. The availability of gender-affirming care services for those who need them is critically important. In addition of psychological impact of gender dysphoria, in South Africa, people face high levels of transphobia, and there are many attacks on trans individuals. This means that access to hormone therapy could mean life or death. 63% of those we spoke to wanted access to hormone therapy at the public health facility. However, hormones are mostly only available in big cities in Gauteng, Western Cape, KwaZulu-Natal, and Eastern Cape. Trans people who do not live near these cities must travel long distances to get these services. This keeps it out of reach for those without access to transport money and places to stay. Only 43% of trans people said that clinics could even offer any information as to where they could find access to access hormones. In addition to hormones, staff facilities should be respectful of gender identity, using people's preferred names and correct gender. However, only 40% said staff were always respectful of gender identity. Worse still, 27% of trans women we spoke to had been told that they had to use men's corner or male only clinic days. We now move to recorded stories.
My name is Kagiso Itlhakanyani, known as Miss K, a transgender person. I'm from Joburton, but currently living in a informal settlement called Jacaranda. That is where I get treatment, or this where I go and consult when I need a clinic. So the clinic that I go to, there is nothing, there is seriously nothing wrong with the treatment, how they treat us, but also there is nothing wrong. I mean, there is no medical information with regards to being a transgender. I used to go to Shawela. I used to travel to Shawelo in Soweto to get treatment. So then I made a decision of not going there anymore because it's far and I'm currently unemployed. So things have changed, roles have changed. So the little bit that you have, you save. So when I went to the clinic, and now I went on a mission, it was just a little mission of finding out, isn't there estrogens that we can take, of which when I went to the clinic, I went with my box, the box of tablets that I had with me, that I got Goshawela, and then I went to show them, and I was told that no, the medication is no longer being given out to menopause people due to the fact that what cancer and what not. And I was like, do you understand what transgender is? And I was the one explaining to someone who studied to be a nurse. I, an administrative person, was explaining that, and it looked like she had no clue. it looked like I'm speaking about Mars, Jupiter, and Pluto. So I was like, oh, okay. But then, of late, it's only now that they are getting the idea of what a transgender person is, because I regularly just go to the clinic just to ask if if there has not been any change, and to this day there's nothing.
So di-services tse dintsi as MSMs ha re di kry-e, la re le di-trans ha re di kry-e, hormonal therapy ha re kry-e because of batla go bolela gore dilo tseo di batla di-specialist, dilo tseo go to Joburg, ra tsamaya ya di-Joburg re ya ko kae. Ke tswa nkile ka nna ka ya ko Shawela clinic ka tsa treatment ko Shawela, ke stopile because of treatment, because of di-fair tsa every month tsa go ya Shawela, because of ko teng ke ne kry-a di-hormones ke kry-a le ate yaka. So I stopped because of every month tshwanetse ke ye ko ke plus minus 300 rand go ya Joburg every month, plus dijo tshwanetse o je mo tsele o je mo wa bana. So ke feel go expensive for a person like me or unemployed. We need to have people like me in facilities so that they can know how to treat an MSM or key population.
Next, we'll be looking at the availability of contraceptives, sexual violence, and sexual transmitted illness services. A number of people interviewed who wanted to access contraceptives were unable to get them at the facility, having increased from the last year's reports. As with general population healthcare users, key populations also at times face stockouts and shortages of contraceptives at the facilities, where their first option was not available. However, in addition, key population are at times refused access to contraceptives, specifically because they are a member of a certain key population group. This is of particular concern and an additional abuse facing people who are using drugs, sex workers, and trans people that need to be immediately resolved. Not everyone who wanted to access STI treatment was able to get it at the facility. Only 80% of the gay, bisexual, and men who are sleeping with other men reported being able to access it. 72% of sex workers and 80% of trans people. For those who attempted to access STI screening and testing services, only 70% of gay, bisexual men who are sleeping with other men, 65% of sex workers, and 79% of trans people said that the staff was respectful. Too often, we hear reports of key populations being discriminated against, of staff acting in a hostile manner of those trying to access these services. South Africa faces a well-documented epidemic of gender-based violence, including homophobic and transphobic attacks on the LGBTIQ+ community members. Sex workers also face extreme levels of violence and forced sex at the hands of the clients, partners, and even the police, who are meant to be protecting them. It is very critical that the key populations who face sexual violence feel safe enough to access these necessary services at the clinic, such as HIV testing and PrEP, also STI treatment and emergency contraceptives, the J88 form, rape kits, counseling, and referral to domestic violence shelters. However, the majority of key populations interviewed did not think that the staff were well trained to care for those who have experienced violence. Only 35% of gay bisexual men were sleeping with other men, 41% of sex workers and 46% of trans people thought that the staff was well trained, and only 55% of GPMSM, 57% of sex workers and 57% of trans people felt very comfortable seeking care if they faced violence from sexual partners. One sex worker told us, "Most of us get raped by clients, and it is very hard to even report this because we are known as sex workers and we are not taken seriously. They say we brought this upon to ourselves." We now move to recorded stories.
Sometimes re a dula ka dikgetsi tsa rona tsa rape because a re na motho o tla re a gang gore wa itse o tshwantse o ha o rapeilwe o dire 1 2 3 re a ya ko tleliniking, but ha o itla ko tleliniking o re o rapeilwe ya no go sa police station hey motho o rapiwa o ka ya ko strateng bosigo wa ibona ya. So it's hurting us so much gore re be re sena sampie e tlhaloganyang our work gore re kgone le go kry-a medication wa rona ya ba di ARV tlang dipilisanyana tsa AIDS le di tsa kam wa ibona ya. That time you are not disclosed yet mo bathong ba bang, but the neighbors already saw you gore okay o nwa di ARV ha ba kgone go bua le rona sentle. And then ha e ka nna gore clinic ya rona ya improve re batlelwe professional sister o tla sensitiziwang gore rona re batho ba ba yang, and we're not staying at one place, relocator. Sometimes I'm in Potchefstroom, sometimes ke ko Mafikeng, sometimes ke go kae, and then ka date ya medication I'm coming back home ke gone ke tla tlang ke tlo go tsa medication then be ke tsamage ke ya ko.
Thank you. Now we'll call Mr. John Ochero, the country director for Global Fund. Unfortunately, he has to leave us soon, so we will ask him to respond to the report, and then we'll continue with our presentation. John?
Yeah, thank you very much, Chair. Can you hear me?
Yes, loud and clear.
All right. Yeah, so I think it is now good afternoon. Good afternoon, participants. All protocols observed. I think I would like to first of all start by thanking all the presenters for the very clear and succinct presentations made. I also want to thank all the KPs who have given their testimonies. I would like to say that the Global Fund welcomes this second edition of the Ritshidze report on the state of the healthcare for key populations. And I congratulate and thank all partners who have been involved in collecting, organizing and analyzing this data, which ultimately have generated this report. The findings in this 2023 report constitutes a wealth of community generated evidence that must and hopefully will guide the way in which key population programs are designed and implemented. The report, however, makes some very somber reading. The report shows that there are quite a number of issues. It underscores many of the challenges that people from key populations face when accessing, or even maybe it's better to say that when trying to access, because a lot of them don't access the services at all. Now, the issues of poor staff attitudes, the lack of privacy, limited knowledge, stigma, availability of basic services are some of the main key barriers that continue to prevent a significant part of key populations from accessing the care. And the report underscores the fact that 12% of key populations participating in the survey reported that they were not receiving any services anywhere. So these findings actually speak to all partners in the response and require our collective action. We need to ensure that all service delivery avenues provide friendly, respectful, confidential, flexible services, access options to all key populations. And we also need to investigate timely these reports of instances where this is not happening. We know that these issues are not only affecting KPs, they actually affect the wider PLH IV population, including very key populations, the adolescents and young people. We've already had young people talking about the attitudes that are represented towards them. That is really quite concerning. So addressing these challenges is key, and we need to support service providers in the adoption of new and more positive attitudes and behaviors. Ultimately, from my personal view, the long-term solution is being able to have seamless service provision in all service provision points, including health facilities. We all know that health facilities are spread all over the place, and they are the ones that people are much more able to access. We have read from the report that there are problems with people having to pay lots of transport fee. They have to pay overnight for overnight stay if they have to go to drop-in centers and wellness centers, which are not everywhere. So ultimately, the health facilities should be as friendly as possible. We should have seamless service everywhere. But of course, we also recognize that some specialized services will still need to be provided for some for key populations. For example, we will still need some safe spaces such as drop-in centers and mobile clinics. Yeah. So in a nutshell, giving communities, and in particular the most marginalized communities, the ability to monitor the quantity and quality of services provision is very critical for people-centered service delivery, so that problems can be highlighted and corrected collectively, and get us all closer to a more equitable health system. As I think you all know, the Global Fund is fully supporting the community-led monitoring as the preferred approach to collaboratively address barriers and improve the quality of health services. In particular, and similar to Ritshidze, we are actually especially focusing on supporting key and vulnerable populations to identify and monitor local barriers and advocate for improved quality, accessibility, and affordability of services in facilities and community settings. We have worked closely with our partners, lead partners, PEPFAR, and many other stakeholders to ensure that we are actually aligned, because this is something that we are doing together. It is something that we can only achieve when we work together. Now, although under the current grant, the Global Fund grant, the CLM activities are still starting off because we just signed our grants last year. We are still in the first year of implementation of our grants. We are still not yet even at the end of the first year. We recognize that a lot of work has already been done into mapping and evaluating the existing CLM approaches, and also work done supporting the development of a national CLM framework. We've been working towards that together with all the key partners. Yeah, so for us, the existence of the various CLM mechanisms is a wealth for the country, but also calls for greater coordination so that the CLM, the community-led monitoring activities, generated data can be well used for decision-making and advocacy, and in engagement with the duty bearers to bring the change that we need. We need to make sure that this data is used. We shouldn't put it on the shelf. So this report is really a wealth of information, and we should use it. And I encourage the periodic, reporting, like annually, as you have started with these Ritshidze reports. So we hope that the Global Fund investments will build on this progress and leverage the lessons for effective and impactful responses. From our side, we look forward to working with all stakeholders, and we also look forward to having a state when all KPs can access health services without fear of discrimination. So I would like to thank you now, and I would like to apologize that I really have to leave at the top of the hour for an engagement that was pre-scheduled, but I've really enjoyed the last 2 and so hours, almost coming to 3 now hours. It's really been very interesting, and I wish you all a great deliberation. And I will, of course, follow up, get the conclusions and the conclusions of the discussion. Yeah, looking forward to receiving those conclusions and declarations for moving forward. So thank you, and back to you, Chair.
Thank you very much, John, and thank you for spending 3 hours with us. We really appreciate it. We really need to continue to engage with Global Fund also now, because you are also investing on community-led monitoring. So without wasting any time, now we'll hear from community members in the room.
Greetings to you all. My name is Anonymous from Durban. Lapha eDurban, mina ngiyi-sex worker, and
I'm a sex worker in Durban.
so in mid-year last year ngiye ngaba nenkinga ye-STI, and yaqala like i-rash and ngangayinaki yabo. So ngaqhubeka nomsebenzi wami ngoba imali bengiyidinga.
I was infected with an STI sometime last year. I did not pay much attention to it until it was a bit late because I needed the money and I had to keep working.
So le nkinga benginayo igcine i-developer yaba isilonda besingaphansi la kumina besivele ngaphandle. So lesi silonda lesi singinike inkinga ngangokuthi besengasakwazi ukuthola imali. So ngabona ukuthi ngesimanga ukuthi bengisebenzele town and imali bengasayenzi bese kusondele nane date yami ukuthi ngiyo collect medication yami. So i-medication bengiyi-collector e-polyclinic kwaMashu.
I collect my treatment at Polyclinic in Kwamashu.
So angithanda ungasho bafethu. So nge-attitude yama staff, ama-members staff, yo mangena laphana shuthi ngiyamxoxela, like ngiyamtshela isitory sami ukuthi njengoba ngila ekubeni sengihlala usuku lonke ngikwi-queue yabo, ekubeni futhi bengi-experience iy'nhlungu ngaleso sikhathi, ngahlala ngaze wafika isikhathi sami sokuthi ngikhulumeke nayo unesi lo engizekeni. Mangena ngaphakathi ngimtshela isitory yabo, lonto sonke isitory sami ngingamfihleli yabo. Emva lokho ungena kwami ngoba mina ngithi like bengi-drug user yabo. So lapho ngaleso sikhathi bengekho i-condition like right ukuthi uyakhohlwa.
When I eventually had the opportunity to go inside and explain to the nurse my problem, I also had to come clear about my drug using habits and also the fact that I was a sex worker, and I had to lay everything on the table just to be honest with the nurse so that they can be able to assist me properly.
So nesi wakhona ngithe mangena qala shintsha ubuso ayibo. Ake ngihlale phansi ke ngikhulume naye. Emva lokho asukuma avula isicapha namawind yabo. Athi kwashintsha iphunga nje la endlini yabo lonto hayi nginganaki ngoba vele nami condition yami ngangiyibona yabo.
So the nurse stood up, opened the windows and the doors, saying that there was something stinking in the room all of a sudden since I had come in, and I had no way of disputing that because I had also come to a point where I realized that my STI was at a bad stage.
Esikhundleni sokuthi sanginika usizo lo lengangili-expectile ngangilidinga, kunalokho wangitshela ukuthi ngoba nginale nkinga enginayo angihambe ngibuye nopartner wami.
So instead of her assisting me with the problem that I had had at that time, she requested that I go home and come back with my partner.
And lapho ngazizwa ngiphatha kabuhlungu ngoba ngangimxoxelile istory ukuthi kwenzakaleni, and anganga-understand ukuthi mangabe ethi angihambe ngiyolanda upartner wami ngizomthathaphi ngoba phela mina ngimtshelile ukuthi ngiyi-sex work.
That didn't make sense to me and was somehow disturbing because I had explained prior that I'm a sex worker, so which partner was she expecting me to bring to the facility?
So ngahamba usizo engcine ngalitholanga, and emva kwalokho ngishiya i-medication yami ngayiduba ngangokuthi ngase ngithi no, I must let it go yabo, ngivesane ngiyeke ne-medication yabo lonto.
On that day, I left the facility without being helped, and I also defaulted from my treatment because I felt like there was no use for me to go to that clinic because of the treatment that I was receiving at that facility.
So abafethu ke then sengibaxoxelile abanye ngibaze bangitshela ukuthi no, usizo ngalithola ka-TB HIV care ose Morningside.
So I spoke to my fellow peers or colleagues who advised me to also go to TB HIV care, which was or is at Morningside.
emva kwalokho ke ngabatshela ke story sonke emva kwalokho bangisiza ngayikwazi ukuthi bangikhanselisha bangitshela ukuthi ngayiqala i-medication yami benza konke okumele ukuthi bekwenze ukuze ngikwazi ukuthi ngibuyele ngithathe i-medication yami ngendlela ade ngiyithatha ngayo.
At TB HIV care, they counseled me and motivated me to go back to my medication and be sure that I adhere to my treatment. That's when I went back to my treatment, and they also assisted me without any discrimination related to the STI that I had had.
Lo wangiphatha kabi kabuhlungu ngangokuthi ilapho engabona khona ukuthi no ngesupport engithole ka TB HIV angisukume nami ngilwe ngempilo yami ngangokuthi ngibonga i-behavioral harm reduction center ngoba mina ngiyi-product yakhona bane program laphana yoku it's an OST program lapho ke ngisizakale khona ngikwazi ukuthi ngiyeke ama drugs.
I also got help from the harm reduction program that I was also referred to by the TB HIV care institution for me to be able to stop using drugs, and I got assistance in that way.
And ngithanda nokubonga futhi wonke lama organization lawa asisizayo asilwelayo ukuthi nathi sikwazi ukurecognizeka njengama sex workers njenge key population. Ngiyabonga.
I would also like to thank and appreciate all of the organizations that come together to help us as sex workers and key populations and make our rights recognized. Thank you.
Greetings to everyone. Okay, I go by the name of Sbusiso Pesi Lubisi. I'm from Pumalanga in Komazi. So I was brutally beaten by 4 guys, raped as well, and I was stabbed on the neck, on the muscle that join the neck and the shoulder as well. So fortunately, I did manage to go to NAS clinic. So when I arrived at NAS clinic, it was later on in the evening. It was 7 o'clock. So I found out as to say they were changing shift. So the nurse says to me, they can't assist me because they are changing shift. I ought to wait for the next staff, which they were changing shift with. I waited in the queue. I was bleeding. I was in pain. So I kept on asking as to say, ain't there anyone who can assist me? And they say, no, there's nothing that they can do. I ought to wait in the queue up until my line, or I do arrive into the into the consulting room. So on my arrival into the consulting room, I met this nurse. She asked as to say what happened. I explained everything, told her what happened. She was shocked, surprised as to say, you are a guy? I say, yes, I'm a guy. She says to me, why would you allow other guys to beat you instead of you fighting? Why would you allow other guys to rape you instead of fighting? What kind of a man are you? Are you a gay? And I've said, yes, I'm gay. She said to me, you are a disgrace, can't you see that? So what does your family say about you being gay? Do they know that you are gay? Do they know that you go around sleep with other men? What does your guilty conscience say to you? I became broken to an extent whereby I regretted as to say where was I going from the first place. So she called the other staff to say, come and hear this guy. She say, oh, he say he was raped. I was in the consulting room waiting. There were patients waiting there. I heard them on the other consulting room saying, there's a guy who says he's raped, he stabbed, all of those things. And then she came back to me and say, you know what, I cannot assist you. Before we can assist you, you need to go to the police station and have a referral letter so that you can be able to assist you. I then asked him, can you please write me the reference letter? Because I'm bleeding, I'm in pains, and I can't hold the pain anymore. Because the wound where they stabbed me, it's deep. I can feel it. Even on my hand, I was cutted. And she says, no, there's nothing that I can do. It's either you go to the police station or you remain here. It was 11 o'clock in the evening by the time. And these other ladies gave me 20 rand and said, you know what, go catch a local. I did went to the police station. And unfortunately, when I arrived in the police station, the very same treatment that I was given into the clinic is the very same treatment that I received. The station commander did call out the whole staff to come and see the guy who claimed to be raped and beaten by other guys while he is a man. So first of all, it didn't. I was like, okay, where are we going to get assisted, or where are we supposed to go and get help? Because at the clinic they referred me to the police station. The police station are busy giving me the same treatment that I did receive go clinic. Okay, I ended up collapsing. I fainted, in fact. So I woke up at the hospital on the following day. I spent it 4 days, if I do remember correctly. So when I woke up, fortunately I did manage to view the file. The story that I did told the police, it's different from what was written. There was no way written that I was raped. It was only written that I was stabbed and beaten, that's all. I felt like my rights were violated, because from first place I was supposed to be given PEP. I'm here, I'm standing, affected with HIV, from which if ever they did something, I shouldn't have been affected of HIV. But I didn't manage to do that. And on my return, I was there to collect my treatment. Instead of them giving me treatment, she was like, here's the guy who was raped. Will you be able to get help? Or you beg, what are you doing here today? I did say, okay, I'm here for the collection of pills. Oh, for the treatment. So meaning that you are affected of HIV. So I felt offended because she was speaking or talking in front of everyone, in the presence of the patients, disclosing my status. Since from that day, I never ever went to nurse clinic. And I never ever in my life say I want to take treatment. I struggled a lot to an extent whereby I dropped out of college because I couldn't manage to face people. Going out each and every day knowing that I was raped. I did went to the clinic and I couldn't get help. I had to stay home. I requested for counseling. Even today onwards, they never ever offered me counseling. I never spoke to anyone. Debriefing to someone as to say what happened to me. I must live with the wounds. I must live with the tragedy that happened to me. They told me they don't have counseling into them. I struggled a lot to an extent whereby at some point I felt like I could take my life because it's no longer worth it. Even today onwards, I'm still struggling with the wounds that happened long time ago because I was denied of access just because I'm a GP MSM. Thank you.
Sanibona. Mina ngiye ngaba nenkinga ye-raped.
I was once raped.
So kuneklinikhi engaya kuyona iphilani kade ngangireshiwe shuthi amaphoyisa afike angishiya khona ekliniki.
And was taken to Pilani Clinic by the police after the ordeal.
So unese kwakumele angisize akakwazanga ukungisiza ngahlala isikhathi eside because why disclose ukuthi ngi-HIV positive vele engakaze kodwa ezezengisize.
So the nurse that was supposed to help me diagnosed me with HIV before assisting me.
So ngahlala ngabona ukuthi okay usizo angilitholi ngase ngahamba ngaya esibhedlela ila ngafike khona ngathola usizo.
I eventually left the clinic without being helped and took myself to the hospital.
Enye into engicabanga ukuthi usister it's because wayazi ukuthi I'm a sexy worker.
I think the nurse didn't help me particularly because she knew that I was a sex worker.
Ngiyabonga.
Thank you. Thanks.
Yeah, we are a bit disturbed, and this is hard. Oh, last one, sorry.
She's anonymous. All the way from Limpopo. All the way from Limpopo. A couple of years ago, I was sick. I didn't know if I had an, what do we call it? STI. Yeah. Or I didn't know if it was a drop or it was an yeast infection. So I went to Nobody Clinic. When I got there, I was assisted by this other nurse. I can't tell the name. So she asked what was the problem. So as she was asking me what was the problem, okay. Kara ke tsebe gore problem ya ka ke eng. I told her that I didn't know what my problem was. Then ka mo tlhalosetsa gore ke feel so. But I explained the symptoms that I was experiencing. Okay. Then I beat the other nurse. She called in the other nurse A re tla go bonetse ke di bonang ka mo. and asked them to come see the surprise that I'm giving to them on that day. Okay, nurse ya le yona ya botsisha gore go tlhagang le yona ka mo tlhalosetsa. I had to also explain again to this other nurse my symptoms. Okay. So a re mo go nna re emelela o bule lefastere le la wa re bolaya. They asked me to stand up and open the window because I was killing them with the smell that I had had. So I'm butcher go tle jwang gore o felletse o ba ka mogobeng ka wana. And asked how did it come to this point that my STI had advanced. So I had to explain that I'm a sex worker. Yes. Then after explaining, they called another nurse and explained that we are dealing with a sex worker today. Okay, so that other nurse said this one has to come with her boyfriend. And I told her, I'm a sex worker. I don't know where I got this sickness. And they said, oh, since you're a sex worker, it means you make money. So why don't you go to a private doctor or something? So I was forced to leave the facility without being assisted. So from that day, I was out of prep. I had to then come back another day to collect prep. They told me to go collect the prep where I had previously gotten it from because they are the ones that allow us to sell, to do the work that we do, sex work. Since the prep, so the loops, if they denied to give me the prep, and I also requested for lubricant. They told me that they don't have lubricant, but as a person that sells my body, which is a very degrading term to use in our native language, then I should know where to get the lube. Luckily, my friend introduced me to CPC mobile clinic. For the STI that I got. Then from there, bumper prep, lady loops, everything is sharp. Every month, after a friend referred me or advised me to go to CPC clinic, it's a mobile clinic. That's where I got treated for my STI and also managed to keep collecting my prep on a monthly basis, and I get any form of assistance, including the lubricant when I need it.
Thank you. You know, it's hard to listen to these stories, and the issue of attitude is a very serious issue. And as I'm sitting here, I'm becoming so disturbed because the deputy minister just said we need to encourage people to use facilities and group themselves. So the question that comes to my mind, how are we going to do that? If people are treated like this, if people are denied access because of their sexuality and what happened to them. Also, before I read the recommendation, you know, last year we were here in the same place talking about condom and lubricants that are not available for key population. And today we are here again saying the very same thing. And it's disturbing that every time we hear promises, we hear that, no, we have read the report, we acknowledge the Ritshidze report, but at the end of the day, there's nothing that is being done. So these this data that we are collecting, we're not just collecting it for fun. We are collecting it for it to be used as an evidence and to improve services on the ground. We are collecting this data from real people, not just numbers. These are real stories, these are real people. So we would like the National Department of Health to start treating this data as human beings, not just something that we can shine with. And when we speak in any platform, we refer to it as Ritshidze data. It says this Ritshidze data. We acknowledging only it's not enough. We need action more than acknowledgement. We need to save people's lives. That's what we are for. We are collecting this data so that life can be saved. That is why our slogan says saving people, saving our lives, because we are on the ground, we are poor, we are disadvantaged, we are the ones who need these services more than ever, but we are the ones who are mostly denied. So I would like to ask, and I'm still asking nicely because I'm trying to deal with my inner peace, to say Department of Health, Deputy Minister, Minister Phahla, I don't want to come to your doors shouting and screaming, because it's easy for me to do that, but I don't want to do that now. We are approaching a strategy where we are saying, let's sit around the table, let's talk about these issues, let's work together, let's go on the ground, let's make sure that people are accessing services as they are supposed to. So I know we are behind time, but I think we can, if people can bear with us so that we finish up. Here are the recommendations. Facilities should be held accountable to put condoms and lubricants in a range of spaces across facility, waiting areas, toilets, gates, pharmacy, consultation rooms, quiet areas out of sight, so people can freely collect them. Add signs to lubricant and condoms dispensers boxing saying that explain they are free to take. Add checking condom and lubricant supplies to the cleaner checklist so that dispensers box are always full. Ensure no staff ever tell key population to use Vaseline or other oil-based lubricants instead of water or silicone-based lubes. Ensure that PrEP is offered to everyone, including key population who are not living with HIV or who are HIV negative, with information shared on its benefit. Add nurse checklist. Respectfully ask people their correct gender and what pronouns they prefer, and remove colored folders that marks people's gender. Ensure clear referral pathways and linkage between facilities and drop-in centers or key population designated sites. The Department of Health and PEPFAR should expand the Center of Excellence model to ensure that at least 2 public health facilities per population per district serve as key population designated service delivery centers. These sites must be allocated additional staff and resources to provide comprehensive health services to the specific key population being served. Ensure that condom compatible lubricants, external and internal condoms, and other barrier prevention are easily available at all public health facilities. Ensure that harm reduction services are made available at public health facilities, including methadone and drug dependence support. The Department of Health and PEPFAR should ensure that trans people are able to access hormone therapy and gender-affirming services closer to home. Provide easy referral and adequate resources, including transport money for transport for people who use drugs, and trans people uptake those services. Ensure that key population are being offered voluntary hepatitis testing, including reinfection, when accessing HIV prevention, treatment, or other harm reduction services. And the preventative HPV vaccine should be offered at the time of return of HIV results, depending on other health condition, previous treatment experience, and potential drug-to-drug interaction. All people diagnosed with HPV and or HCV should be offered treatment, care, and linked to wrap around services.
Thank you, Chairperson. We now next will look at drop-in centers and mobile clinics. Compared to public health facilities, drop-in centers and mobile clinics generally perform better from the perspective of all key population groups in terms of service acceptability and service availability. As expected, key populations using drop-in centers and mobile clinics had far higher satisfaction levels compared to those using public health facilities. However, these satisfaction levels are decreased from the last year's reports. Again, this year, mobile clinics had lower satisfaction levels than drop-in centers, where key populations report that mobile services are inconsistent and are not always accessible close to where they are staying, particularly those in rural areas or staying in areas that mobile clinics feel unsafe entering. However, most key populations we interviewed are not using either a drop-in center or mobile clinic to access services. In fact, Ritshidze data shows that a very high proportion of key populations are not even aware of any drop-in centers, including 79% of gay, bisexual, and men who have sex with men, 75% of people who use drugs, 74% of sex workers, and 71% of trans people we spoke to, and overall use of drop-in centers is limited by this lack of awareness. For those who are aware of drop-in centers, the distance and cost to get to them can be prohibitive and mean key populations are unable to use them. Now let's look at attitude, safety, and confidentiality at drop-in centers and mobile clinics. Given that drop-in centers and mobile clinics are specifically set up to meet the needs of key population, and a more friendly and professional attitude should be expected. However, there are still improvements that should be made to ensure that all key populations have positive experience at a drop-in center, a mobile clinic, or other KP service delivery points. For instance, only half of people who use drugs think the mobile clinic staff are always friendly and professional, and only 77% of sex workers think drop-in center staff are always friendly and professional. Any allegation of poor attitude should be investigated and corrective action taken. Key populations felt somehow safer and more comfortable at drop-in centers and mobile clinics. However, many interviews still did not. Only 37% of people who use drugs felt safe at drop-in centers, and only 22% of gay, bisexual, and men who have sex with men felt safe at mobile clinics. That is safe and protected from verbal abuse, verbal or physical abuse, verbal or physical harassment, and risk of arrest. Similarly, only 45% of sex workers felt comfortable at drop-in centers, and only 20% of trans people felt comfortable at mobile clinics. That is, are treated well and get the help that they need. There is much room for improvement to ensure that key populations are able to access these sites and feel safe and comfortable to actually use them. Again, drop-in centers and mobile clinics perform much better than public health facilities at respecting people's privacy. This year, 3% of gay, bisexual, and men who have sex with men, 12% of people who use drugs, and 13% of sex workers, and 4% of trans people had concerns about privacy at drop-in centers. And performing less well, 18% of gay, bisexual, and other men who have sex with men, 18% of people who use drugs, and 9% of sex workers, and 19% of trans people had concerns about privacy at mobile clinics. As you can see, there's room for improvement, especially at mobile clinics. We now move to the recorded stories.
So ngagcina ngibona ukuthi okay ngingcono ngimuvele ngoba beku abomgaqweni ngazama ukukhuluma nomunye usisi wayesebenza kwi-mobile clinic yabo ngamtshelisi ngoba bebefika ke bona bezivakashela even though ngayikhumbula inhlangano bebesuka kuyona bo uthola ukuthi bas-provide ngalawo ma-condoms ngamaphilisi like uthola ukuthi basifundisa nango-prep ukuthi ukuze ungatholi bekunani indawo ke lapha la bengihlala ngakhona uDalton uthola ukuthi banendawo la bebeka khona ama-condoms besizakala nakhona bo but ile ama-STI bibhlungu kakhulu ngoba besingathola ukusizakala sibedlela bo thola ukuthi angikwazi ukulokhu nje ukuthola usizo angithi ngibambula yini la nami sometimes ngibona ukuthi hey mhlawumbe ukuhlala kuseni from 6 to mhlawumbe abo 4 5 yabo lonto angidlile anginalutho ngicela nami ngize ngibona ukuthi no angihambe yabo yeah ngagcina yesi ngisizo omothi lo ngawusizo usisi lo wayishop wathi angugcobe ngaphansi otherwise usiza ngithola ngasibedlela bona banginika amaphilisi engabona ukuthi hayi umehluka ngubona bo yes vele abangijikanga ngaphansi abo bona banginika amaphilisi okuyiwona amaphilisi agcina angangisebenzelanga ngoba ngabona ukuthi mangayisukumele ngoba phela mfethu njengoba ngichaza ukuthi le ndawo yona bengiphila ngayo abo
August lena last year 2021 yabo rango August ngiyeke khona njobe siqala lento imile yabo njobe siqala imile mangifika khona ngifuna usizo ngilithole from the first day bangidress up iwundi yami bagcobe nemithi le yakhona second day mase ngibuya shuthi kune staff nurse esihlala ngasekhaya esiwu-neighbor wami yabo staff nurse sakhona la Hlengisizwe clinic it's a Hlengisizwe clinic from Hammersdale yeah mangifika ke khona athi lo sisayibo uthini lo uthini thiwa unenkinga la umilwa into angayazi kanje athiwa athi kufanele usebenzisa ama drugs lo that's why lento yakhe ngeke nje iziport it won't heal because it's still using the drugs. You must stop the drugs, then we can treat you from this thing. Yabona nje leyo ingeni ngashock ukuthi hawu uthini lo muntu kumele phela iclinic le kusizala wonke umuntu wathi futhi nina futhi maphara nihlezi la nize ngathi nizofuna usizo yabo ekugcineni mase nitholile lo sizo lelo jike nisitshontshele futhi yabo ngiyamtshela sonke asifani yabo hayi ukuthi sonke mfethu siyabasiyona leyo nhlobo so until ke mfethu ngize ngithole umfethu wangasekhaya bejwayele ukuza la eThekwini yabo angitshele ngelento harmful reduction center le lapha eMbili TB HIV ya step up yize ke nayo le eThekwini ayingihambe ngekhona hawo abona ke nje laphana ingathini umuntu onjengathi yabona oyimisele ngokushintsha empilweni onenkinga willing futhi ukwadla amaphilisi eHIV bayamthanda bayamnakekela kangangokuba baze bakubuza indawo ohlala kuyona ukuthi where you stay yabo sihlala la ema-shelter ke thina ematendeni yabo hlala lapho it's where we stay they even bring the medication to us if kukhona inkinga yabo i-drop-in center le ela eThekwini ngaze ngamuva ke Hammersdale ngiveza ngala ngoba ngibona ukuthi okay at least ngiyalithola usizo ngala futhi abangicwasi yayibona leyo nto yeah hayibo in public phambi kwabantu ayithi kubabona uma beqhamuka nelento njani kuthiwa inamafayili la wakhona nisuke vele nulayini lapho mina ngiyavuka ayikho vele into engisuke ngibhizi ngayo yabo qhamuka nje phambi kwabantu nje la yabo during that time into nje if ingiphathe kabi bengazi ukuthi nje okay it's a drug elizokwehlisa lesi stress lesi yabo ngoba kwayona le opinion yakhe ngaze ngayithatha ukuthi shothi ngempela lento yami ngeke mfethu ize iphole ngoba naku still ngisasebenzisa ama drugs yabo bengingathanda ukuthi nje ngathini indlela esitreatwa ngayo ibe equal yabo so even ilento njana ngathini ilento yomuntu status somuntu bangasimemezi nje noma kanjani yayibona yonto ya status babe in a privacy nje kahle wonke yabo uma ngase uye ku each and everyone i-drug use akekho oyi-drug use othandayo ukusebenzisa ama-drugs each and every one of us there is no one nje ongathi hayi mina I like to use drugs. All of them, they are willing to change, all of them, yabo. Manje, if there is a support, yabo uma ngabe umuntu kunokuthi encourage discourage uthi hey leyo nto yakho ngeke iziphole ngoba vele you are still a drug user, it won't heal the thing, yabo. Leyo muntu uchaza ukuthi now i-drug user leyo nto iya-effects nje la emqondweni, ya ngasho lapho from that time eyishouta lento yakho ukuthi awuvele nina nisuke nizontshontsha la you are thief and stuff, yabo. Nenze ngathi nizofuna usizo kanti niyadrayisa. Ngayisukumela ngabona ukuthi okay okusho ukuthi la sengiyabandlululeka ngoba nalabantu esengihlele emaceleni kwakhe lo ukubaboneka abantu iphara balithatha kanjani plus bengisayi-hard smoker during that time. Same time ngisukume ngihambele ekhaya benginika nemali yokugibela-ke, yabo. Asebenzisa yona-ke kwayona leyo mali ngavele ngayo ibhemele.
Sanbanan.
Greetings.
I'm a sex worker. I'm coming from Durban, KZN. Currently, I'm very angazi singathini yazi ngiyi-sex worker ngibuye eThekwini ngizophakamisa usizo esitholayo as ama-sex worker.
I came here to talk about the type of treatment that we get as sex workers.
Kwi-mobile clinic esisebenzisayo or facilities u-TBK.
At the TBK mobile clinic.
Okay, mina bengisebenzisa i-clinic yangakithi elokishini.
I used to use the nearest facility close to me.
That clinic was in my location. My location is from Ilovo. And the treatment that they was treating us there, it wasn't not good. It was very bad. It's not like the main of approach is the main thing in the clinic. It's very, very, very bad. Soon as they know that you are a sex worker, or it's either you use drugs or you been on those other kind of things that's out of roots, so it seems like you are not a human being. So you've been treated like an animal. But since after this, I get closer to TBK, I did get a very good service to TBK. I like to say thank you very much, TBK. Go forward and further. Make sure all the time you take care of the sex workers together with our other fellow sisters members that they also use drugs, same like us, because we can also use drugs because we cannot sustain to be sex workers to 24 hours. We're having sex with two different men and all those kind of things. So you have something like to jog yourself. Thank you very much.
I'd like to remain anonymous. I'm from Eastern Cape. The main point for me is that we're being denied access from those mobile clinics that comes to our communities simply because we told our friends that know people in places. So I was denied the medications for hormones by the vets trans organization. So they told me that I need to have a transfer in order for me to get those hormones. So since that day, I've asked them, so when I get the transfer, what must I do? They told me to go to the nearest clinic. Thank you.
Now we'll be focusing on the KP-specific services at drop-in centers and mobile clinics. While there is increased availability, lubricants are not always available at drop-in centers and mobile clinics. Only 77% of GBMSM, 73% of people who use drugs, 78% of sex workers and 91% of trans people said that they could always get lubricants at the drop-in centers. These are key prevention services that should be fully available at sites specifically servicing key populations. While more key populations were offered PrEP as drop-in centers as compared to a public health facility, numbers remain low, with only 43% of gay bisexual men who are sleeping with other men, 51% of people who use drugs, 24% of sex workers, and 63% of trans people saying that the drop-in centers offer them PrEP even though they are not living with HIV. This is a major missed opportunity in HIV prevention. It is also worrying that PrEP was not reported as being widely available at either drop-in centers or mobile clinics. This could be a lack of availability or a lack of awareness of services available. Both issues need to be investigated and resolved. While better than public health facilities, harm reduction services at drop-in centers and mobile clinics must be improved. Only 48% were given information on where to get methadone, and only 77% were able to get drug-dependent support at drop-in centers. Only 65% of people who use drugs said that they could get new needles at drop-in centers. People who use drugs explained to us that they can't get needles at the facility, but that's also they can only get needles from PEPFAR, the partners, every 6 weeks. So still we have to reuse needles or buy them themselves in the meantime. Gender affirming care is not widely accessible, even within the drop-in centers targeted at trans people. Only 34% of trans people using the drop-in centers said that they could get hormones on site, while 23% were referred somewhere else, and 31% were given no information at all. Yet 78% of trans people said that they would have liked to access hormones where they were currently getting services. Drop-in centers and mobile clinics were more respectful to trans people, correct gender, although again there is much room for improvement, especially at the mobile clinics. Not everyone who wanted to access STI treatments was able to get it. For example, only 74% of gay bisexual men who are sleeping with other men reported being able to access treatment at the drop-in centers, and only 73% of sex workers reported being able to access treatment at the mobile clinic. While better than public health facilities, more can be done to ensure staff are well trained to care for those who have experienced violence, and that all post-violence services are made available. For example, only 81% of sex workers said that they would be comfortable accessing post-violence services as a drop-in center, and only 73% of gay bisexual men who are sleeping with other men said that they would feel comfortable to access those services at the mobile clinic. We're now going to be moving to recorded stories. Is it? Our recommendations.
Thank you. The recommendation, PEPFAR and Global Fund should ensure all drop-in centers and mobile clinics always provide friendly, respectful, and confidential services to all key population. Urgently investigate all report of poor staff attitude, privacy violations, verbal or physical abuse or harassment, reports of services being refused, denied, and ensure consequences management where necessary. A full breakdown of facilities will be provided. For facilities, we report on PEPFAR. Global Fund should respond within 3 months with action that have been taken. Ensure that a minimum package of services is provided for each key population group at all drop-in centers. Ensure that condom-compatible lubricants, external and internal condoms, and other barrier prevention are easily available at all drop-in centers and key population services delivery models. PEPFAR and Global Fund should ensure that harm reduction services are made available at all drop-in centers, including methadone and drug dependent support. Ensure that trans people are able to access hormone therapy and gender affirming services closer to home. Provide easy referral and adequate resources, including transport, money for transport for people who use drugs and trans people to take those services. Ensure that key population are being offered voluntarily hepatitis testing, including reinfection when accessing HIV prevention, treatment, or other harm reduction services. And the preventative HPV vaccine should be offered at the time of return of HIV results. All people diagnosed with HPV and HCV should be offered treatment, care, and link wraparound services. Thank you. That is the end of our long presentation. So, I think we had stories from the people, we had recommendation, and I'm happy that I've been seeing people taking notes, and I think soon we'll be working towards on how are we implementing this recommendation with all the partners that are in the room or are responsible. So without wasting time, I will ask Jerry to respond and representing PEPFAR. Thank you. You can stand there. You can stand.
Good afternoon, everybody. We made it. I just want to thank you all for your courage and your willingness to share your stories with us confidentially or in person. It's not easy, and we want to just say thank you for inviting us into your space. Thank you also to Ritshidze and the leadership and the staff and the volunteers who did the surveys, conducted the 9,000 interviews to gather this rich data that compels us all now to action. So thank you for that as well. This has been a very difficult event. The stories that we heard were very heartbreaking, and I don't think anybody can leave here without wanting to be part of the solution. And I think all of us have to think, what are we going to do differently today, starting in 5 minutes when we leave this tent to improve services. No one should experience humiliation or harassment when they seek care, and when one person in this room is discriminated against, all of us should feel that discrimination, because we know and we've heard over and over again that we're not going to end AIDS unless we close these equity gaps. So we must all feel the pain and own the solutions and carry that forward. Our comrade over there said when he was bullied, he was also a bully, and he bullied his way into services. And while that's inspiring, and we thank you for that, it shouldn't take bullying to get the services and the dignity that each and every one of us deserve. And so thank you for being a bully and for inspiring us to all be bullies to get to action. I just want to finally say PEPFAR stands with you. PEPFAR is committed, like Global Fund, like our partners, UNAIDS, USAID, and CDC. You'll hear from my colleagues as well, to carry forward these recommendations, to embrace these solutions. The solutions are here. I don't think we need more discussion, more deliberation. You have the solutions, and we look forward to having discussions as we begin our COP23 process over the next few weeks. But I think we can make some solutions even within the COP22 programming that is underway right now. So I'm looking forward to discussing that with my team when we go back. So thank you again. Thanks for inviting us, and I look forward to ongoing discussions.
Thank you very much, Jara. So I will ask people from National Department of Health who would like to respond, who are here in the room. Is there anyone who would like to speak on behalf of National Department of Health or Department of Health? Even if it's not national then. Okay. It seems like we have somebody on the line. Do we?
Okay. Good afternoon, colleagues.
Good afternoon,
Can you hear me?
Regina.
Yes, I am Regina Maitufi from the National Department of Health, managing the STI and the Key Population Program. As a department, I would like to say that we acknowledge this report in order for us to improve the services. At the moment, there are a lot of activities that are taking place at the ground, and then we are working closely with our partners to assess the facilities, to offer mentoring and coaching at the facilities, and also to train the facilities. And then one of the things that we have identified as a game changer is the utilization of the key population peer educators, who are really playing a very critical aspect in terms of navigating the key population to the facilities. So we are working with that, and also looking at our conditional grant to make sure that we appoint key population peer educators who should be working in the facilities. And then one of the game changers that we think we will see the result on is the development of the key population health implementation plan. We have been working closely with CDC and ORAM and other organizations to make sure that we develop a guide for the facility and also community approach. So we are finalizing the guide, and then we are hoping to see the changes. And then we have also developed the M&E framework with reporting tools, and we will also see that we report as the Department of Health on the progress that we are doing. And then we have also taken an advice from the recommendation that we need to write circulars, and in that we will make sure that we effect that. And then, as I've mentioned, sensitization training is taking place, mentoring and coaching is taking place at the facilities. And then with regard to the IEC material, we have taken a stock of the IEC material, and then we will also make sure that as we review the IEC material, we will also involve the key population. And one of the things that is also important, we have developed the TOR for Technical Working Group. It was supposed to take place today, but we will look at the date, because the aim of the Technical Working Group is to ensure that we meet as partners and as province to deliberate on this report that we've just received, and also to deliberate on the implementation at the facilities, even at the community. So these are some of the interventions that we are putting into place, and then looking forward to more engagement with you. and also to invite maybe one of you to our technical working group meeting to really see to it that really things are happening. And then we are seriously going to make sure that the recommendations are implemented. Some of the things that we can, that we cannot, then we will also make sure that we work closely with PEPFAR and other partners in the ground. Thank you very much.
Thank you very much,
Good
Ritshidze.
afternoon.
Yes.
Afternoon. Speaking, it's Ribwana Lefiga from the National Department of Health. I just wanted to indicate that we've noted the concerns about lubricants. Lubricants are currently being manufactured in the country, so as the NDOH will ensure that we communicate with the provinces to ensure that they order enough stock, because we shouldn't be having shortages of especially lubricants because they are being manufactured locally. So another area of improvement that we noted is the fact that provinces and NGOH should also work closely with other organizations that are not government entities that are working with key populations so that they are able to access lubricants and condoms directly. And we are also going to try and find ways to improve communication and reporting, because as it was highlighted, we can't just there can't just be findings and reports, but nothing is done about it. So I think the challenge here, it will be that we get information in platforms of Ritshidze, but as time goes on or as months are going by, we are not getting this report, so that we are actually noting them and try to see ways of improvement. So that's an area of improvement that we are also going to do, whereby provinces have to continuously report in terms of the lubrication that they are distribution across all facilities. Thank you.
Thank you, Livuani. I'm not sure whether is there anyone else also who would like to respond from the Department of Health? In the absence of none, thank you very much. And thank you, comrades, for acknowledging what we've been experiencing. And we would like that at least next time when we have such community accountability meeting, we have something nice to talk about, to say at least from this time to this time, services have been improved. We don't like to be here just to complain and talk about bad attitude, but we would like also to talk about good things that are happening in the department. So working with you, comrades, I think it will assist us to reach that stage. So without wasting any time, I would like to ask my sister, Eva Givango, Country Director for UNAIDS, to respond.
Thank you very much, comrade. I've taken some notes, which I'll look at, because I have a feeling if I don't read from my notes, I might break down a little bit. It's been very heavy. Yeah, it's been a very heavy day. So first of all, thank you to Ritshidze for the invite to participate in today's meeting on the state of healthcare for key populations. Congratulations for all the hard work, and thank you for the very rich, granular data. And as Comrade said, behind those numbers, there are people. So this granular data is going to help us to unpack the iniquities that you are facing as key populations. And it comes at a very important time because we're going into a lot of planning for PEPFAR COP23, so this is really useful information. I've been honored and privileged to be here to hear your testimonies. You are so brave, all of you are so brave. Your stories were Diroba Pilo. Is that correct?
Yes.
Yeah.
You got it.
Yeah. It's heart-wrenching, as Gerard said. And I'm very proud of your courage. You know, I couldn't, as some of you were talking, I couldn't even look at you because of the pain I was feeling. You're all human rights defenders. You are fearless. How do you say that in your language? You are fearless. Wataba, you're fearless. You know, I was listening to you and taking notes, and what I was writing down were all the things I was hearing, and I'm going to read out some of those things that I was hearing. Bad attitude, unfriendly, stigmatized, afraid, denied, degrading, traumatized, always explaining, in pain, raped, judged, embarrassed, inappropriate, humiliated, not heard, violated, turned away, always explaining, demeaning, transphobia, shamed, humiliated, not assisted, suicide, defaulted, where do we go, uncomfortable, treated like an animal. But I also heard a lot of solutions. And I heard you when you said you need to be engaged and included in the solutions. You can fight for your rights. You are real people. You are human beings. Your dignity must be respected. You must be treated equally. You have the evidence and you know what works. And it is about saving our lives. So thank you for the concrete recommendations. For the different partners, that's something we had asked for. So it's not just PEPFAR, but thank you for breaking it down. So it's very clear what the Department of Health has to do, what PEPFAR and Global Fund have to do. I completely concur, completely agree on the importance of community leadership, of you being involved, so that you can decide on how the services should be provided. I want to thank PEPFAR for your continued support of CLM, and to thank the Department of Health and the AIDS councils for their engagement. It's very important. And to reiterate, to repeat, I know I must remind myself not to use big words, we like doing that. To repeat the importance, to emphasize the importance of community-led monitoring, to advance equitable programming, and I want to recommit UNAIDS support. We are with you. We are working closely with Ritshidze, and we will continue to do that until we end AIDS and we make sure that everybody has access to the dignity and services they deserve. Thank you.
Thank you, Eva, and thank you everyone who has taken some time to come for this community accountability meeting, and for your responses. It's very appreciated from our side, noting that you are always here to listen and you are always here to work with us. And I would also like to thank all our participants. Without your stories, nobody will know what is happening out there. And it's brave, really, for you to come out and telling these stories, which are not easily being told. And it's not easy, even in our community, to talk about our gender, the work that we are doing, what we are facing every day. But you were brave enough to say, I will come out and I will speak, and I will speak on behalf of all those who cannot speak for themselves. So thank you very much, comrades. So without wasting any time, I think we are at the end of our program. And we had a very hot, sunny day, but you were patient and you were with us up to the end. Thank you very much. I think there's a light lunch prepared for colleagues. So please enjoy and have a good afternoon. Thank you very much.